Okay, good morning, everyone. It is 9 a.m. We are just anticipating Jason to be joining soon, but we will get started. Um, Welcome to the July 18th, 2024 licensing. Satinder, your camera is not on. There you are. Thank you. Welcome to the July 18th, 2024 licensing committee meeting. My name is Sang Oh, chairperson of the committee. Before we convene, I'd like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law, where protection of the public is inconsistent with other interests sought to be promoted. The protection of the public shall be paramount. As I facilitate this meeting, I will announce when we are accepting public comment. I have advised the meeting moderator to allow 3 minutes to each individual providing comments. We will begin with public comments for individuals attending in person, followed by public comments by individuals participating via WebEx. Just a quick reminder as well that we will have to adjourn around 1:15 p.m. today to provide enough time for staff to have meal break, as we have another committee meeting, communication and public education meeting starting at 2 p.m. As you can all see that we've had a little overzealous agendized items, so if we don't get to any of them, we will just discuss them at the full board meeting. So this approach is necessary to facilitate this meeting, and before we get started, I would like to ask staff moderating the meeting to provide general instructions on the process for providing public comment via WebEx. And I see Jason's joining too, so go ahead, David.
When the time comes for public comment, we're going to ask people wishing to make a comment to raise their hands. You can do that by tapping the hand button at the bottom of the screen. Dial-in users will need to dial *3 to raise their hand. And for our mobile device users, you have 3 different screens and only one of them has a hand button. So you may need to hit the ellipses button, that's the ... at the bottom of your screen, in order to find that hand button. As stated, people will be given 3 minutes to speak, and I'll give you a 10-second warning before your time expires. President O?
Thank you, David. I'd like to take a roll call to establish a quorum. Trevor Taylor.
Here.
Good morning. Renee Barker.
Good morning, licensing member present.
Thank you. Jesse Crowley.
Licensing member present.
Thank you, Jesse. Satinder Sandhu.
Licensing member present.
Thank you, Satinder. Jason Wise.
Morning, public member.
Thank you, Jason. And I'm here. A quorum has been established, members. As I said, we have a full agenda for our meeting today. I ask everyone participating today to be respectful of the work before the committee. We encourage participation by members of the public throughout our meetings at appropriate times. The committee respectfully requests that when comments are provided, they're done so in a professional manner, consistent with how the committee conducts its business. Before we move to the next agenda item, I would also like to remind members participating via WebEx to please remain visible on camera throughout the open portion of today's meeting. Members, if you need to temporarily turn off your camera due to challenges with internet connectivity, please remember to announce the reason for your non-appearance when you turn off your camera. And finally, I'd like to ask staff to send out a link to all board members when the live stream of the meeting is available. This will ensure members that are interested to have an opportunity to review the meeting prior to the full board meeting later this month. Thank you. Moving to the next agenda item 2, public comment on items not on the agenda item for future meetings. I will ask the moderator to open the line for individuals to provide the opportunity to provide public comment. You're not required to identify yourself, but may do so. I would also like to remind everyone that the committee cannot take action on these items, except to decide whether to place an item on a future agenda. Following review of the public comments for this agenda item, I will ask members to comment on what, if any, items should be placed on a future agenda. As a reminder, this agenda item is not intended to be a discussion, rather an opportunity for members of the committee and members of the public to request consideration of an item for future placement on an agenda, at which time discussion may occur. Are there any members in Sacramento? I don't see anyone in there.
No members of the public in Sacramento.
Thank you, Anne. If you could please announce if there's anyone in there. If not, I will just go straight to WebEx throughout today's meeting.
Happy to do so. Thank you.
Thank you, and we're ready for public comment in WebEx.
We are open for public comment for items not on the agenda. If you'd like to make a comment, raise that hand by tapping the hand button at the bottom of the screen. Dial in users, dial *3 to raise a hand. And as a quick note, we also have a Q&A section in the lower right-hand corner of your screen where you can type the word comment and send that comment to all participants in order to get in the queue. Our first request comes from Jackie Stover. Hold on just a moment, Jackie. We're going to send you a request to unmute your microphone.
Hi, my name is Jackie Stover, and I am a specialty pharmacist. I wanted to take this time to thank the Board of Pharmacy for their continued efforts in securing an author to sponsor the amended Section 4071.1 of the Business and Professions Code, Sections E and F, and specifically F as it relates to remote processing. I was also wondering who at the Board of Pharmacy is responsible for seeking an author for this bill. Is there something that we can do to help expedite this process? Once again, thank you for your time and attention to this very important topic.
Thank you for the comment.
So we're going to hear from Inez Anton. Hold on just a moment. We're going to send you a request to unmute your microphone.
Oh, can you hear me?
Yes, go ahead, please.
Okay, my name is Inez Anton. I'm a California licensed pharmacist, and I work for a specialty pharmacy, and we used to do remote processing for 3.5 years with no problems. However, you guys accepted a waiver for the healthcare facilities to continue remote processing and not for us, although we serve the public and we serve patients, California patients and other patients in other states. We work for a specialty company, and all other states approved remote processing. However, it's not approved for California. We wonder why. We know that the board could not secure an author by January 2024. We're not sure who is responsible for that, and we are not sure if we can do anything to expedite this process. So please advise if we can do anything from our side. And we thank the board for all the efforts in securing an author or a sponsor to the amended section 4071.1 of the Business and Profession Code, specifically the section E and F that relates to remote processing. And thank you so much for giving me the opportunity to comment.
Thank you for the comment.
So we're going to hear from the letter C. Hold on just a moment. We're sending you a request to unmute your microphone.
Hello there. My name is Cindy. I'm here to support all the previous two commenters and ask the board to give us an update or at least let us know what's going on with the processing issue that was approved, and we'd like to know if it's being worked on, and if so, what is the status? Thank you very much.
Thank you for the comment.
Those were all of our requests for public comment.
Thank you, David. Members, any questions or concerns or anything that you want to speak before we move to the next agenda item? Okay, seeing none. All right. Next agenda item is agenda item 3, approval of April 10th, 2024 committee meeting minutes. As we begin our consideration, I will ask members if you have any questions or comments on the draft minutes from the April 10th, 2024 meeting. I would also entertain a motion if you believe such action is appropriate. Members?
Hi, Sung. This is Jessie. I move to approve the minutes from April 10th.
Thank you, Jessie. Any second for Jessie? Thank you, Trevor. Oh, thank you. Thank you, Trevor. All right, thank you, Renee. With a motion and second on the floor, I will open the discussion for public comment on the April 10th, 2024 draft minutes. Are there any members in WebEx?
We are open for public comment via WebEx. If you'd like to make a comment on the motion, please raise a hand by tapping that hand button at the bottom of the screen. Dial in users, dial *3 to raise a hand, and we will call on people in the order we have requests. As a reminder to our mobile device users, you may need to hit the ellipses button, that's the ... in order to find that hand button. We're going to wait just a few more seconds before we close public comment. Seeing no request for public comment, do you wish to continue with the motion?
Yes, please. Thank you, David. With a motion and second and public comment, we're gonna ready for a vote. Trevor?
Yes.
Thank you, Trevor. Renee?
Yes.
Thank you, Jesse.
Yes.
Thank you, Satinder. Okay, thank you, Satinder. Jason?
Yes.
Thank you, Jason. And I vote yes, the motion passes. Next is agenda item 4, discussion and consideration of proposed amendment to Business and Professions Code sections related to the definition of pharmacy technician trainee. Members, as you may recall, during the past several meetings, the committee has received presentations on and discussed pharmacy technician training programs, including employer-based training programs. We noted at that time what appeared to be great variability in the quality of employer-based programs and suggested perhaps the need for greater oversight of such training programs. Also, during the January meeting, we discussed work being performed by the Office of Professional Examination Services, which is performing an occupational analysis for the board for the pharmacy technician licensure program. The results of this analysis may help inform the committee in its assessment of training program requirements moving forward. As noted in the meeting materials, as part of those discussions, we noted that the current definition of pharmacy technician trainee is currently limited to a person enrolled in a pharmacy technician training program operated by a California public post-secondary education institution or by a private post-secondary vocational institution. As currently defined in the law, the definition does not extend to an individual completing an employer-based training program. During our discussion in April, we determined it was appropriate to remove the current limitation. I believe it is important to note that while we are expanding the definition to encompass additional training programs, the provisions for a training program will remain consistent, including requirements that a training program cover all knowledge and understanding of different pharmacy practice settings and laws and regulations governing the practice of pharmacy. I'm highlighting this to ensure there is clear understanding that an employer-based training program cannot just be solely focused on that specific pharmacy or type of pharmacy. This is in large part because once issued, the license allows a pharmacy technician to work in a variety of settings, not just the pharmacy where they completed the employer-based training. I would also like to remind everyone that the provisions related to externship requirements for a pharmacy technician trainee will apply irrespective of the individual's pathway to functioning as a pharmacy technician trainee. I'm just highlighting that to ensure everyone has a clear understanding of the hours limitations established in the existing law and the applicability of those provisions. Also, just wanted to make sure members had a chance to receive the materials and the letter that was attached to you all a little bit late last night. So hopefully you all had a chance to look at that. Members, attachment 2 of the meeting materials include a copy of the draft statutory language prepared by staff. I believe it is consistent with our prior discussion and direction. However, I am open for discussion and comments. And so let's open up to see where your thoughts are on this issue, members. Oh, are we gonna have a quiet crowd today? I mean, oh my goodness, it's
Hi, Sung.
okay.
This is Jessie. I'll hop in. Um,
Thanks, Jesse.
so I did see the written comment regarding this agenda item. I guess I want a little more clarification. It was my understanding that the board does approve the employer-based training programs. Is that correct?
I'm gonna defer that to Anne. I don't think so, but Anne?
The board does not approve employer-based training programs. Rather, the regulation details the requirements that any technician training program must meet. So
And
they need
Anne,
to comply with the regulation section.
while you're at it, would you mind just covering that briefly, since I know you're an expert in that regulation sections 17 somewhere.
So not an expert. Thank you for the confidence though. But let me just pull it up. It is at 1793.6. And essentially the employer-based training program would fall under 1793.6 C1. And included in that is a training program of at least 240 hours of instruction that cover various types of elements of training. So knowledge and understanding of different pharmacy practice settings, knowledge and understanding of the duties and responsibilities of a pharmacy technician in relation to other pharmacy personnel, knowledge of standards and ethics, laws and regulations governing the practice of pharmacy. It also requires knowledge and ability to identify and employ pharmaceutical and medical terms, abbreviation symbols commonly used in prescribing, dispensing, and record keeping, knowledge of and the ability to carry out calculations required for common dosage determinations, employing different kinds of systems, knowledge and understanding of the identification of drug doses, routes of administration, dosage forms, and storage requirements, knowledge of and ability to perform manipulative and record-keeping functions as specified, knowledge and ability to perform procedures and techniques relating to manufacturing, packaging, and labeling of prescription drug products. So those are like the core elements, and I just want to highlight Chairperson O, President O, similar to what you talked about, right? The employer-based training program cannot be limited to just the employer work site because they would not be meeting some of the elements of that. So the training needs to be broader. So from a practical standpoint, we do audit some of the training programs to confirm compliance, but the board does not approve them in advance, if that makes sense.
Thank you,
Does
Anne. That is definitely helpful. I think I was under the impression that these programs and the content of the programs were filtered or submitted to the board in some way. And so I do have similar concerns to what the written comment was alluding to. I've just personally witnessed some of the programs, at least in years past, really not covering just the basics for technicians, let alone some of the expanded duties that would allow them to perform in other work sites. And so I am a little hesitant in that sense, specifically with employer-based programs. And I'm kind of curious to see what everyone else's thoughts are too.
Thank you, Jassy. All right, Satinder, your hand is raised. Go ahead, Satinder.
My understanding is that the summit.
Sorry, and just a heads up,
Okay.
your audio
Okay,
I
thank
think is a little delayed. So you got the 7-second delay going on over there, a very fancy, like a real broadcasting situation. So just keep that in mind for us.
Okay, appreciate it. Thank you. Thank you. So what I wanted to comment on was that my understanding is that some of the employer-based programs are actually accredited by ASHP and PTCB. And I think in those case scenario, since they're being offered, but there's not an opportunity for those students to actually practice under the supervision. I think if the program is accredited and if by ASHP, which the board accepts, and PTCB, which the board accepts, and they complete that program, I think this would be a great way to give those students a practical experience prior to getting licensed. that I want to add.
Okay, thank you for the comments, Satinder. So you are thinking as a balance, just to maybe adding that requirement instead of striking out just technician program operated by California Public Post-Secondary Education Institution, blah, blah, blah over there. We could just add technician training program that are accredited like that way.
Yes, I think that, yeah.
So that not everybody can just call a willy-nilly technician training program.
And it would not need to be a board approved, and like that way it's already accredited. Board already has said that they will accept these accredited programs, and then this just allows them to have a practical experience prior to getting licensed.
Okay, sounds. Thank you for the comments. And I think I just want to add that the original reason was one, there's always and has been, and I think is continuing to be a shortage of pharmacy technicians. And so we were just hoping to find ways to add a ways for people to wanting to be technicians. And that was the original intent, just to throw it out there. Trevor, go ahead.
Yeah, I was just curious, are there any examples are there any other states that have this sort of employer option? Would this be a new thing for California, or are we following a model that's been proven successful elsewhere? Just wondering if this has been tried elsewhere to do this kind of model.
Thank you, Trevor. And sorry, Anne, I'm gonna pawn that off to you. You may or may not have an answer, but from my limited knowledge that I know, Arizona has a technician trainee, I believe, and now this is possibly an old, outdated knowledge, but I know at least when I was doing an internship there that they had something like that. So they had some opportunities for people to be called that so that they can gain experience. And I think this would be nice so that in some ways we run into the challenge where you should have some experience, but you cannot have experience because you're not a technician, and you're not a technician, you cannot do these things. So there's no practical ways for them to practice. So that's why I think having some sort of trainee title would be helpful. And so they can actually gain experience. With that, Anne, sorry, I don't know if you know any responses to Trevor's comments and questions.
So we're happy to research that at the staff level. In a general sense, states take different approaches to regulating pharmacy technicians. Scope of practices vary. Their authorized duties, I guess, is a better way to say that. Licensing requirements vary greatly. Some of them don't have the same number of pathways to licensure as the board does. So we're happy to look back on it, but do some research. But there's great variability nationally about the regulation of pharmacy technicians.
Okay.
Thank you, Trevor. Satinder?
So my understanding is that, yes, there are other states that just allow just from the experience. Matter of fact, I think California, prior to going to this route, used to allow X number of hours to be certified by the pharmacist supervising and for them to be allowed for technicians. And I do agree with President O's assertion that this allows a great pathway for some students to be technicians and not pay thousands of dollars to private schools to go through it, and which is a prohibitive for becoming a technician. And if we have a program that's really sound and certified, and this would be a great opportunity for some people to have a technician career and therefore reduce the shortage and reduce the workload that pharmacists and stress levels that happen in the pharmacies. So that's all I wanted to say.
Thank you, Satinder. Renee?
Hi, thank you. Yeah, basically kind of following off of what what you said, President O, about providing an alternative pathway from the accredited schools. much like Satinder said, I think it is a route that, due to the cost, can be prohibitive for some technician, some potential technicians. I do understand the concern for the training. I don't think, hopefully people don't take it lightly to have a technician trainee program. But I do find in my own experience that when you have a technician who's just gotten out of school, and you take them, and it's also a challenge, right? Just everything the more hands-on. And so I do think that it could be done well. As to how it should be done well, that combination of education combined with real experience simultaneously, I think, like Satinder was referring to, I think the technician pathway years ago, before there were licensed technicians, you hired you hired people to be a technician and you trained them. Now we're not trying to go that route again, because obviously there's more education. The job is much more complex now for technicians. But I would hesitate to say the word accredited. I just don't know what that might mean. I think somebody might have to be able to show the board, if like Anne is saying that, they might do sort of spot checks. How are these, employee training programs going? How are they structured? And if, somebody would really have to be able to speak to their program. Here is our program, not, so all that to say is I would hate to not have this pathway by having a term like accreditation, which means like, does the board take on, something else? I mean, obviously, if something like the ASHP accreditation is available to an employee training program, but they might choose something different. I don't know, but I do think a different pathway for technicians, for a less expensive route of entry, and one where they would probably get paid while they were being trained, or possibly. I mean, again, that's a whole other scenario, but I do think it's very challenging for the technician route.
Hopefully they will be paid, not paid to have experience. Yeah.
Yes, yeah.
But thanks for the comments, Renee. Okay. And Jesse?
Thank you, Sung. So I think I do understand the cost of the accredited programs. And granted, I'm sure it depends on the facility. I think a lot of the larger facilities can afford accreditation. And please, anyone correct me if I'm wrong, but I've worked with technicians who are licensed in the state who have done programs, who have admitted to me that the only thing they did was ring people out at a register, and that's how they got their pharmacy technician license. And so I do struggle to keep it that broad. I understand the need for the on-hands training too, right? Like it is very difficult, and I mean, training alone for a technician really takes years to fine tune. But a lot of that hands-on training, including like working with the medication, is necessary in a lot of ways. And so I would be more comfortable changing the language to be an accredited program. But yeah, that's kind of where I'm at.
Okay. Thank you, Jesse. Not hearing consensus, so I think it might be best that we open up for public comment and see if anyone has anything to say. And then maybe we'll come back and go from there. So we will open up.
Thank you. President O, yeah. I do have to log off really quickly.
Okay.
I will be back sometime around 10 o'clock, but I wanted to double check with staff. Is it easier if I completely log out of the meeting?
Probably. Just so that it looks like you're not here. It looks like you're here, but not here. I know Trevor also has to step up at 9:45. So Go ahead, Jesse. Do you have to leave now?
Sorry, yeah, I do have to leave now, so I'll log off and then I'll sign back in after.
Okay. Okay. All righty.
Thank you.
Thank you, Jesse. Okay, we're ready for public comment.
All right, we are taking public comment. Please raise a hand by tapping that hand button at the bottom of your screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. You may also type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. First, we're going to hear from Keith Yoshizuka, followed by Mark Johnson. Hold on, Keith. We're sending you a request to unmute your microphone.
Yoshizuka. Oops. Not
Go
gonna
ahead,
hear me.
please.
Oh, okay. Two things. One, in regards to the suggestion to check the requirements for technician training in other states. As I've stated in the past, we're talking apples and oranges. In other states, technician duties aren't as specific as they are in California. Several other states, a technician is anybody else other than a pharmacist or an intern that's working in a pharmacy. It could be a cashier or clerk, anyone like that. So it would be difficult to draw a line saying, well, what do other states require? Two, there's concern about, well, how are these folks, these trainees supposed to get experience? And I wanted to remind the board that in existing pharmacy law, there's provisions for a technician trainee above and beyond those to be supervised as licensed technicians. So under current California law, one pharmacist can supervise one technician trainee in addition to the other licensed technicians. So thank you very much for the opportunity.
Thank you for the comments, Dr. Yoshizuka. David?
Help if I unmuted. Next, we're going to hear from Mark Johnson, followed by Jesse Jerwal. Hold on, Mark. We're sending you a request to unmute your microphone.
CVS Health. First off, I'd like to thank the board for this proposal. Currently, our on-the-job training has technician trainees shadowing filling activities. Of course, with hands-on repetitive motion is a much better learning experience. So we are certainly in favor of this. I do have a few comments though. One is while this 1-to-1 ratio can be restricting, I do have a question as it pertains to training facilities and exactly what counts in this 1-to-1 ratio. As we convert a rule that was meant for, secondary education folks being in our pharmacy, I think it might not be as easy as the edits that have been made. I'd like to clarify if in 4115.5, when it says placed in a pharmacy, it means for on-the-job training and not the computerized portion of the training. Much of CVS Health's training are learning modules where folks are sitting at a computer. If they're sitting at a computer and they happen to be in the pharmacy, are they now considered a trainee, or is the trainee only truly when they're on the bench and involved in, filling activities? That clarification would greatly help because, of course, we really don't want a trainee sitting at a computer to count in the 1-to-1 ratio. Also, the way we currently do it is we have a technician who the trainee shadows. Of course, a pharmacist is in control of all supervision in the pharmacy. But we wouldn't want 4115.52 to say that the tech trainer is not allowed to train the technician. Of course, everybody under the supervision of the pharmacist. It kind of makes it seem as though the pharmacist has to be the one doing the training too. So we just don't want to eliminate that. We think it's a great model. Lastly, I'd like to weigh in on some of the arbitrary numbers. CVS can live with things like no fewer than 120 hours and no more than 140 hours. I mean, we can live with shall be a period of no more than 6 consecutive months in a community pharmacy. And we can live with, and for a total of not more than 12 months.
10 seconds.
Majority of our people fit those parameters, but what about maternity leave and other things that create stragglers? Thank you very much.
Thank you for the comments, Mark.
Thank you. Next, we're going to hear from Jassy Jerwal, followed by Lori Walmsley. Hold on, Jassy. We're going to send you a request to unmute your microphone.
Good morning, Jassy Graywall with UFCW Western States Council. First, would like to apologize for a late letter yesterday, but glad to see that you all have received it and appreciate the discussion that the board members have had. Our concerns really lie in making sure that there is some level of accreditation or approval or review of the curriculum to make sure that we don't have bad entities out there putting together trainings that really don't meet the requirements or the intent of the requirements around technician training. We know this from other industries and other experience that there are training programs that have been utilized in other professions when we do remove that level of verification and accreditation. So we think that the recommendation by board member Sandhu really does make sense of just making sure that there's some level of accreditation, which sounds like that is something that current employers are already proceeding with. I do just want to flag more broadly that what we have noticed in our experience from different employer programs is that while the intent of the law is to be broad-based in training, there is a focus on one employer's processes and how that works, which does make sense because we want the workers to know that individual companies' processes, but it is so focused in that area that what we have noticed, especially with the continued consolidation within retail pharmacies, is that it has been difficult for a pharmacy technician from one company or one practice setting to then transfer to another practice setting or company. And we've seen that in real time currently as there are closures with certain pharmacy chains. And so we just want to be mindful of this, which is why we think that level of accreditation does make sense, because at the end, what that ultimately does do is harm patients where these pharmacy technicians are assisting in their pharmaceutical duties to consumers. So we just want to flag that, but do appreciate the discussion and the recommendations of having a balanced approach on this, and that we do want to make sure pharmacy technicians are receiving hands-on practical training, because that is where a lot of the really good learning experience comes from. But happy to engage, and just wanted to say thank you for allowing us to submit written comment and for having received that, and apologies for the late submission. Thank you.
Thank you for the comments, Jazzy.
Next, we're going to hear from Lori Walmsley, followed by Richard Dang. Lori, we're sending you a request to unmute your microphone.
I'd like to thank the board first off for this discussion. I think this is very helpful and very timely. As many of you have discussed, it's very important for us to be able to have trained and skilled technicians. And I appreciate the discussion looking at alternative ways to accomplish that, to make sure that technicians are the most prepared to perform those functions. And I agree with a lot of the comments from the prior commenters that hands-on experience is often the best way to do that. So I appreciate the discussion and look forward to seeing the language as we move forward.
Thank you for the comments, Lori.
Next, we're going to hear from Richard Dang, followed by Stephen Gray. Richard, we're sending you a request to unmute your microphone.
Pharmacists Association. Appreciate the discussion and all the prior comments that have been made. I do just also want to encourage the board to consider programs that are accredited, as all of our other training programs in pharmacy are accredited. PharmD education is accredited by ACPE. Residency program training is accredited by ASHP and APHA. And so it doesn't really make a whole lot of sense to have pharmacy technician training programs not be accredited. I think the intent to expand availability and accessibility is great. I think the intent of more hands-on experience, which I agree is very valuable, is great as well. But I think if we're looking to create a national standard to minimize variability, that having an accredited program is what the board is looking for. Otherwise, if you remove the requirements for an accreditation, then you're essentially asking the board itself to police and evaluate and inspect all the training programs to make sure that it meets the requirements. And I'm not sure the board at this time wants to spend its resources doing that, from what I hear from the prior conversation. So I think encouraging language that includes accredited programs will allow the board to ensure that there is a standard that is being met across the board, which does include hands-on experience in the accreditation standards, while also potentially expanding availability so that it's not limited to only post-secondary education institutions as the current language states. So there's probably some middle ground here with additional language that can be considered, but I would definitely encourage incorporating the accreditation of these technician training programs. Thank you.
Thank you for the
Thank you.
comments, Dr. Dang.
And probably last, we're going to hear from Stephen Gray.
I'd like to point out a couple of things. I know that the issue of accreditation has been raised by the previous speaker and also by one of the board members. There was a conference in Dallas a few years ago where accreditation was discussed across the country with hundreds and hundreds of representatives. And my takeaway from that is that accreditation programs, especially by some large national organizations, are very expensive in themselves to the employer. And that took a lot of community independent pharmacies out of the market of using those programs. Yes, large chains, large non-for-profit organizations with many pharmacies can get their programs accredited, but individual pharmacies just really were suffering and just could not afford those accreditation programs. So keep that in mind. If the goal is to have more pharmacy technicians, there's several things to keep in mind. Also, besides the fact that employer-based programs not only pay often these pharmacy technician trainees, but they also receive benefits, which is a huge draw for people going into pharmacy technician, for their families to get health care, their families to get sick leave, and so forth. So those employer-based programs are a big draw for programs. The other problem with some of the accreditation programs, they often train pharmacy technicians for tasks they would never do. And several of the large chains complained that where a state like Oregon required accreditation, they would spend a lot of money putting their trainees through those programs only to have them hired immediately upon a program. I mean, they're paying them and giving them benefits. And then as soon as they got their technician training, they were hired by hospitals and compounding pharmacies. And so it was just a complete revolving door situation. So be real cautious. There may be some way to have accredited programs, maybe by CPHA or others, that are more designed to the specific needs. As Keith mentioned, pharmacy technicians in other states are really a different category. And what you're really trying to do is to make sure that the pharmacy technicians in California can do the tasks that only pharmacy technicians in California can do. And so all the inputters are trained by the employers because that's not a task that's limited to pharmacy technicians in California. So these are several things to keep in mind when you're comparing what's happening in other states. Thank you.
Thank you for the comments, Dr. Gray. I know, is that it, David? Because I know Trevor has to go. Trevor, before you go, do you want to have any thoughts before so that we can consider that into our discussion?
Yeah, thanks. It sounds like we don't have that consensus. I'm personally leaning more towards maybe an accredited version of this, where it seems like that's kind of the middle ground where we don't turn it into a wild west of anyone and everyone, but we're still making it more accessible. Because I absolutely agree with you, President Sung, that we need to find ways to ease this tech shortage and remove barriers. And the constant question is, to what extent can we remove barriers while also maintaining the level of quality consumers deserve? And I think the conversation here has been a really beneficial way of figuring out how to balance those two priorities. So I appreciate your leadership on this.
Thank you, Trevor. We'll see you when you come back.
Thank you.
Thank you. Okay, with that, members, I know we're just left with Renee, Satinder, and Jason. And I'm sorry to put you on the spot really quick. If it is accredited or board approved, would that require the amount of work that would we be able to contemplate that? I mean, that's probably just trying to figure out if there is a way that we could have a little more flexibility of not just limiting it to accreditation, but possibly having it approved by the board. I'm sorry.
No, that's okay. You're putting me on the spot a lot today. I'm just kidding.
And it's gonna be all day long. It's gonna be happening.
So I think here's what I will say. If the policy direction of the board is to transition to a model where the board is approving technician training programs, we will transition to that model. I'm going to have some, I'm going to have to look at some data to see if we can figure out what that full impact would be. I'm not quite sure we're going to know given our current computer systems, but if that is the direction of the board, the accreditation piece is obviously easy and is already acknowledged in our law. The approval of the board approving a pharmacy technician training program, I think we would want to know if that is specifically if the training program wants to use an individual or allow for a technician trainee, or if you are suggesting more broadly that all of the training programs that potentially fall under 1736.9C1 that we talked about earlier, if you want staff to begin reviewing all of those moving forward. So I think we would just need a little bit of clarification on what the policy goal is, like where you want to go. And then I will need some time to, think about it a little bit and check in with some of my coworkers.
Thank you, Anne. With that, I'm really concerned about the workload that might cause. So maybe I will open up for members your thoughts, but maybe just starting with accredited as a one step. Just wanted to open up your thoughts. Anyone out there? Go ahead, Satinder.
I'll go. So I think we can go with accredited as long as because the way it is right now, these they're getting licensed, but they're getting licensed because let's say they go through some of them go through ASHP program, they complete the entire program, but all they can do is observe and shadow and not actually have a hands-on experience. At least this way, that trainees will be able to get a hands-on experience of 220 hours and be much more prepared as a technician when they are technician and not have delays. So I think I agree that maybe we can just start with accreditation, and then as we get the board, maybe we can look at carve out if they're not have every program to be reviewed by the board, but just if they're not going through an accredited program or the school or attending the accredited school, then that program needs to be evaluated by the board or something like that.
Okay, thank you, Satinder. Renee, I know you are about to speak, so go ahead.
Yeah, this is a challenging topic. I certainly agree with, some of the comments that are kind of somewhat opposing. I think everybody wants to make sure that the technician training programs are quality. And then, it's just a matter of achieving that. I mean, since accreditation is already in there, I think just looking at that, but I would, kind of off of what Stephen Gray had said, I mean, um, I'm just looking at the technician base. I know, I work with a lot of technicians. I mean, we all have, but the circumstances are challenging. And so to go to, these 18-month technician training programs, the cost, the time, the inability to work much while they do it. I mean, I think those are huge, huge barriers. So while we, can guarantee that's a quality program, they still come out and they're still a challenge to, because they don't have a lot of experience. So however, that gateway to having the opportunity for a pharmacy to do the training, but I think the little crux is, how would you guarantee the quality of that one, if they're accredited or not? Because I mean, I looked up, a particular training program, and I think what came up is a couple of years ago, but I mean, it's several $1,000s a year to have accreditation to the pharmacy. So that's a consideration, and we have struggling pharmacies, right? So obviously the larger ones, probably can accommodate the cost, and it does increase by the number of sites. So there is a lot of expense in there, which, unfortunately, like to have expense combined with quality. I mean, that's a tough one right there. So, if perhaps there could be some other route, but I think at this time to move forward, I mean, we would probably need to stick with accreditation, but I think find like what is something we're not doing now that could open up a pathway, because it is like much more appealing for a technician to be getting paid. I mean, so many they're just already struggling that, for that, they're trying a pathway. They want to do better, but then, they need to work. They need to make money. So, and benefits is always, that's a whole other thing. So I think that the draw to increase the technicians, now we would also want it to be, them to have a good education as well. So, all that to say is I think there's something behind, door number C that we don't know quite yet, but I think we need to probably stick with accreditation for the quality, because I also appreciated the comments about the fact that other, pharmacists and residents are all under accreditation. So we do want them to stay professional in that way.
Okay, do I hear a motion? Would you like to make a motion? Anyone wants to make a motion? Possibly considering it. I mean, we're not an attorneys here, so Anne can help us adding that accreditation piece, but I think it could be as simple as accredited pharmacy technician training program. But Satinder, go ahead if you want to try to.
I apologize. This is
I'll try
Anne. Can I just jump
Go
in
ahead,
and
Ann.
ask a
Go ahead,
clarifying
Ann.
question really quickly? So right now in our law, the only accredited pharmacy technician program, which is in 1736A, is the ASHP training program. And just seeking clarification, are you going to go to any accredited program, or that is already acknowledged in our law as appropriate?
I personally would like to expand that, but I'm curious for members' thoughts. Satinder?
I'm okay with expanding that. It just gives them more opportunity to, for, just outside of the two, as Renee pointed out, and some of the public members pointed out, the expense of some of these, already existing programs for the employer. Maybe there are programs that are a little bit cheaper, gives more option to the employer. So I'm okay with expanding to other accredited if they are out there.
But I'm not sure what other pharmacy technician training program accreditation bodies are out there really, other than ASHP. So I don't know, Anne. But if there are, I think that it would be good to open up. Does that answer?
There was
And
I think we heard from the two last time, was it PTCB and what is that other EXCPT
oh,
and the ASHP?
I don't think except or PTCB, do they do accreditation too, other than the certifications? I know those two are kind of confusing topics on its own, but sorry.
Yeah, maybe
and
confused.
I'm going to just run with scissors for just a minute and tell you language that I think might meet the policy goal that I'm hearing. Totally running with scissors right now. Have not run it through council. So there's all of my disclaimers. But I think instead of the language that's in the packet, you would keep the definition of a pharmacy technician trainee, and after the words private post-secondary and vocational education, you would just add or an accredited employer-based pharmacy technician training program.
I think that works for me.
Yeah. All right, then I'll go with, I'll make an attempt to motion here. A pharmacy technician program, so we were adding, so pharmacy technician training program operated by California Public Post-Secondary Education Institution or by private post-secondary vocational institution approved by the Bureau of Private Post-Secondary Education or accredited technician program. Does that
If I may be
satisfy?
bold, if I may be bold yet again, sorry, someone's going to take the microphone from me. I might suggest that a motion may be to recommend to the board consideration to amend Business and Professions Code 4038B to include as an option an accredited employer-based pharmacy technician training program.
So I motion and authorize the board to amend 1438 to include or accredited
employer-based
pharmacy technician program.
Employer-based. Okay. Any second for the motion?
I'll second that.
Thank you. Thank you, Renee. Okay. With a motion and a second. Jason, you've been quiet. So any other thoughts you want to share?
Hi, President O. No, I just think that it is such a complicated issue. I think this certainly requires more work, and I appreciate the work of the board on this. Accreditation does seem some sort of model of accreditation, I think, would be appropriate. So thank you.
Thank you, Jason. With that, we're ready for public comment. David?
We are open for public comment on the motion. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand. And you may also type the word comment into the Q&A box in the lower right-hand corner of the screen and send that comment to all participants. And our first request comes from Stephen Gray. Hold on just a moment. We're sending you a request to unmute your microphone.
Thank you. Thank you very much for the comprehensive discussion. This is a very important program. We do need a lot more pharmacy technicians. We do need to make it easier and better for the pharmacy technicians and their families to have employer-based programs where they can get paid and benefits. I cannot overestimate how important that is. I also want to point out that I think the language that was just talked about would allow for other types of accreditation, other entities to get involved in the accreditation. For an example, as I mentioned, the California Pharmacists Association also can approve for accredited continuing education programs. If we keep the language general, then entities like the California Pharmacists Association and maybe other entities will get into making sure that pharmacy technicians are accredited for things that are important to California. As I mentioned, in other states, the convention in Dallas, the #1 request from pharmacy operators was not for pharmacy technicians to be trained to fill prescriptions or to enter prescriptions in a computer. The number one thing they asked of the accrediting companies was to give thorough training in billing practices. Now, that is not a task that is limited to pharmacy technicians in California. And that's why I think it's very important to make sure that any requirement is tailored to what we call pharmacy technicians in California. And so if the current language will keep that open as a possibility, there may not be such entities now, but you know, the old saying, build it and they will come, you know, so making it available for CPHA and other entities to get into that would be the way to do it. Thank you.
Thank you for the comments, Dr. Gray.
And that was our only request for public comment.
Thank you so much. With a motion and second and public comment, we're ready for vote. Renee, how do you vote?
Yes.
Thank you, Renee. Satinder, how do you vote?
Yes.
Thank you. Jason, how do you vote?
Yes.
Thank you, Jason. And I vote yes, the motion passes. Next, agenda item 5. Oh my God, it's 10 o'clock. We're definitely not going to go through all the agenda items today. We will do our best to cover as much as we can. Discussion and consideration of survey results received related to pharmacist to pharmacy technician ratio. As you may recall, we have previously discussed our intention to focus committee discussion on strategic objective 1.3 related to the exploration and pursuit of changes in law as appropriate for the authorized duties of a pharmacy technician. The committee made significant steps in this area by convening listening sessions started back in 2021 and soliciting feedback from licensees regarding potential changes. The results of these efforts were incorporated in Assembly Bill 1286, which became effective on January 1st. During our October 2023 committee meeting, we initiated a review of the board's ratio requirement. The meeting materials detail the current law related to ratios. We routinely receive public comment indicating that California has one of the most restrictive ratio. As a reminder, review of various state ratios does not necessarily provide an apples-to-apples comparison, as I said multiple times, and as we talked about even in last discussion of technician duties, as jurisdictions have varying approaches on provisions for services within a pharmacy, including where some jurisdictions require all pharmacy personnel to be licensed as a pharmacy technician if performing functions such as data entry. This is not the case in California. I continue to highlight this only to remind us that when comments are received, context matters. And some background, during the January committee meeting, members reviewed and approved a draft survey to solicit feedback from pharmacists on this topic. As noted in the meeting materials, the survey was released on March 6th and ended on March 25th, 2024. During the survey, we received over 5,100 responses, and we are very thankful for everyone who participated in the survey. During the April meeting, we received a presentation on the results of the survey, and attachment 3 to the meeting materials include presentation slides provided at the time. The data was informative, but members requested additional information specifically from survey respondents that did not identify as serving as a pharmacist in charge or working in a management or administrative position. I'd like to extend my gratitude to the experts within the Office of Professional Examination Services for working to develop, deploy, and evaluate the survey results and compiling the additional data for our consideration today. So I'm going to turn the meeting briefly over to Anne to describe some of the additional data. Anne, the floor is yours.
Thank you. Sorry, talking a lot today. Apologize to everyone about that. So just should it be helpful in the meeting materials, attachment 3 are the prior slides. So I'm not going to re-review. I'm just really going to focus on the additional data sets that the board request or that the boarding committee requested. So this first slide highlights that pharmacists working in the institutional setting that are not a PIC or a manager, you will see that about 60% believe that that current ratio of 1 to 2 is correct. The next slide shows that where the individual had indicated that they did not believe that the current ratio is appropriate, you will see that the most frequent response for what it should be then appears to fall into that 1 to 3, which is about 39%. Transitioning to the next slide, please. We're now switching over to that non-institutional. So we have a couple of different slides here. So this first slide is a combination of chain and non-chain, and then we'll be focusing in on those a little bit more. So this first slide talks about pharmacists working in the non-institutional setting. You'll see it's combined. These individuals did not represent as being a PIC or a manager, and you'll see that almost 72% have indicated that the current ratio is not appropriate. If we can go to the next slide then, where they indicated that it was not appropriate, you'll see that the most frequent or the highest response rate was the 47, almost 48% said that the ratio should be 1 to 2 in their beliefs. If we could move to the next slide, zooming in a little bit further, pharmacists working in the non-institutional chain, right? So in that chain environment, you'll notice that about 75% indicated that the current ratio is not appropriate. That's about 75%. Next slide, where individuals indicated that it was not appropriate, right? You'll notice that the highest frequency or the highest percentage of those respondents indicate that they believe the ratio should be 1 to 2, and that's about 46%. Next slide, please. This then shows for those pharmacists that are working in the non-institutional and non-chain, you'll notice that 60% of those individuals indicate that the current ratio is not appropriate. So it's a smaller percentage, but still, well over that 50% mark. And then that next slide, which is our final zoom in here, this talks about pharmacists working in the non-institutional in a non-chain environment where they indicated that the current ratio is not appropriate. The majority of them, about 58%, believe it should be a 1 to 2 ratio. Thank you.
Thank you, Anne. As I reflected on the prior data and reviewed the additional data provided, it seems that the ratio established for the institutional setting may remain appropriate. I found some of the results very interesting, including the responses specifically from pharmacists who've identified as either in management nor serving as a pharmacist in charge. So, in the non-institutional setting, I believe the data supports either the current ratio or maybe 1 to 2, but this is just based on survey, so we all have to keep that in mind. I am going to open this up for our members. Your thoughts on it? Do we believe we have sufficient data to move forward in maybe recommending a change to increase the ratio to a 1 to 2 in a non-institutional setting, aka community setting? Or do we need more information? So with that, I am gonna open it up. Please share your thoughts. Jason?
Hi, thanks, Song. I have a few questions. One, do we have, I apologize, I don't know the status of pending legislation. Do we have an update on that, Anne? And then two, do we have feedback from pharmacists on what level or what kind of support they could have to increase the ratio? Are there things that can be done to help them increase the current ratio?
So the Glacier bill that would have increased the ratio is not moving. It was held in suspense. The survey itself kind of focused more on what that ratio should be, right? Basic demographic information, who they are, that kind of stuff, work environment, and then their beliefs on current ratio. We kept the survey specific to the ratio questions primarily. We didn't go too much broader than that. So we certainly could develop a second survey or a few supplemental questions if that would be helpful to the committee. This is a really complex issue, right? That's why I think the law's been the way that it has for a long time. So, happy to work with others as the committee directs the staff to do so.
Thanks, Anne. I think that we do want to increase capacity at sites. And if there is feedback from the public and fellow board members, I'd be interested in hearing it. Thank you.
Thank you, Jason. Any thoughts, Renee, Satinder? We don't have to have a motion right away. We could also open up for public comments. Any thoughts?
This is Renee. Thank you, Anne. I think those slides were good. Can I just ask, am I missing something? I don't remember seeing those slides in the attachment. Are they there?
Anne's PowerPoint is not in the attachment.
Okay.
Yeah.
I
So
was
you
gonna
didn't miss anything.
stare at it some more. Okay. I do feel like that was a really good pull out of information. Excuse me. Feels fairly definitive from the staffing perspective from a pharmacist who's actually doing the work. So I thought that was really, really helpful. But I would like to know what other people are thinking as well.
Thank you, Renee. Go
Well,
ahead,
thank you, first of all, staff, and for getting that additional information. And it was very helpful, and it is what I suspected. It looks like, especially in a community pharmacy, and particularly when you spread that out even in chain, there seems to be a lot of, overwhelming opinion is to increase the ratio. And when, it mostly if you expand even further, even 1 to 3, and also the pick determining the ratio was also an option. So we're considering those. I was thinking like maybe the board can go with this interim step as a PIC determining the ratio, since already as a staffing challenges that occurred in the 1286, where it gives the pick and the staff pharmacist to determine if the environment is safe based on the staffing. This would be another tool in their pocket, since they're the one who feeling and determine the ratio, and then we can create crafted regulation in such a way that it gives the board the opportunity to revisit and determine exact ratio that could be. And meanwhile, it looks like there's overwhelming desire to take care of this challenge that the community pharmacies are facing. That's all.
Thank you, Satinder. I think that's a great idea about PIC. However, I personally would not willing to support that unless there were stronger language that we could add where it gives further autonomy for PICs to determine staffing levels and really adjust. I think that in a perfect world, that would be the ideal solution. But I think that unfortunately in the current environment, there's just not enough, support, I would say, for that to be a realistic benefit to the rank and file, the actual pharmacists and pharmacy technicians and pharmacy managers and PICs working in the stores to be able to make it work. So I'm thinking more 1 to 2 as a baby step, with the hope that we could make a very strong language that the pharmacist on duty or pharmacist in charge may refuse to supervise a second pharmacy technician, as that is the language that's already in our pharmacy clerk section of the law. So that's what I was thinking. We do not have to move forward on this today. We just want to put it out there to see if there's any other information that you would like to know before we can move forward. But I think that there's enough data at this point for us to possibly contemplate making a motion for us to have a support of increasing the ratio, which would be pretty remarkable step for us, for our pharmacy technician world. We've had the 1-to-1 ratio probably for God knows how long. So, but at least this is a committee support, committee motion. So, I mean, if you're ready to do that, we're ready to contemplate. We can also open up for public comment before, whichever you all prefer.
So I'd be willing to make that motion for from 1 to 2. Certainly want to make sure that however we can put controls in place to protect the pharmacist's rights, PIC's rights. Would like to include that if there's any way to include that in such a motion.
Thank you, Jason. And can you help with that part? I just want to make sure that it's very clear that we are adding that into our
So,
motion. I'm sorry again. I'm
no,
sorry, Ann.
that's okay.
Please forgive me.
Yeah,
There's,
I would
you can't.
maybe
Thankfully, you
think.
can't throw something at me through the screen. So
I think, it could be something along the lines of recommend to the board an amendment to Business and Professions Code Section 4115 to increase the ratio of pharmacist to pharmacy technician to 1 to 2 in the community pharmacy setting, something along those lines with authority for the pharmacist to refuse to supervise a second pharmacy technician. And we can refine the language before the board meeting if that this is not part of the motion. Happy to, if happy to refine the language and run it through the committee chair before we would put it in any meeting materials.
okay, sounds good. Jason, is that agreeable to you?
Agreeable to me. Thank you.
Sounds good. Any second for Jason's motion?
I would second that. This is Renee.
Thank you, Renee. All right, sounds good. We are ready for public comment.
We are open for public comment on the motion. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. And our first request comes from Keith Yoshizuka. Hold on, Keith. We're going to send you a request to unmute your microphone.
Thank you very much for the opportunity. This is Keith Yoshizuka. May I respectfully suggest that maybe as part of the sunset review that you transfer the authority to establish technician ratios to the board to determine as a regulation. I believe that the Board of Pharmacy is in a better position to gauge what is safe for the public rather than a group of legislators who know nothing about pharmacy. Much in the way that the board has the authority to determine the ratios in the institutional setting. That way the board can be a little bit more nimble in adjusting, and also as such, as we have heard from previous public input, that not all community pharmacies are the same. Under that umbrella, you have home infusion pharmacies, you have specialty pharmacies, and some of these pharmacies, closed door pharmacies, and some of these pharmacies lend themselves more to like an institutional environment. So that would open the door for individual pharmacists or pharmacies or PICs to request possible waiver or variance, so they could change, for example, a home infusion pharmacy where the pharmacy is just compounding all IVs all day, and is basically the public has no access to that pharmacy. I really think that the board should have the authority to determine rather than having to go back to the legislature each time. Thank you very much.
Thank you for the comments, Dr. Yoshizuka. Just making sure that Jesse seems to have returned, just for the purposes of for the record. Hi, Jesse. Welcome back.
Thank you. Hi, Son. I'm
We'll
here.
go
Can
back
you
to you.
guys hear me?
We can hear you. We're talking ratio, so after public comments, we'll go back to you to make sure you have your share of comments. But we
thank
do
you.
have a motion on the table. Motion is to increase the ratio to 1 to 2 essentially, but with a little bit of caveats. But
Okay.
go ahead, David.
Next, we're going to hear from Richard Dang. Hold on just a moment. We're sending you a request to unmute your microphone.
California Pharmacists Association. We are in support of the board's motion and direction to increase the technician ratio. As I mentioned in your previous licensing committee meeting, based on the survey data and on member discussion and surveys with our stakeholders as well, we have found that there is a very large majority that is in support of increasing the technician ratio. So we appreciate the board's discussion and would like to see this continue to move forward. Thank you.
All right, thank you. Next, we're going to hear from Andre Peterse. Apologize if I butchered your name. Please let us know how to pronounce your name.
Almost there, Andre Peters. I has also been part of CSHP's efforts through our Government Affairs Advisory Committee in looking at the proposed bill for technician ratios. And I think what, in me speaking to a lot of pharmacists about this, I did sense that there was a little bit of a fear of the unknown in what the changes in ratios would bring. And that may play into some of the responses. I agree very much with Keith Shizuka, who said that the fact that somebody may have a retail license doesn't necessarily mean that it is a chain or a true patient-facing retail operation, in that there is a variation where a lot of those pharmacies do act like they are institutional pharmacies, and I think we have the opportunity to go ahead at this point in time and maybe try and incorporate those kinds of pharmacies as well. In looking at this, I realized that most states in the USA have ratios that far exceed 1 to 1, like we do in California, or even 1 to 2. And there are some states that even have no limits on pharmacy technicians. So I do agree that it is certainly time to take a look at ratios and see if we can make some changes. Given some of the comments from my comments and Dr. Yoshizuka, I would recommend taking a look at a proposal that would say we would consider a 1 to 2 as a standard, and but also leave it up to the PIC to increase up to even a 1 to 4 ratio, or and also retaining language where the PIC can also refuse to increase the ratio should they deem so appropriate. Thank you very much for the opportunity to provide this comment.
Thank you for the comments, Andre.
Next, we're going to hear from John Gray. Hold on just a moment. We're going to send you a request to unmute your microphone. John, are you with us? You may need to dial star.
Sorry about that. Yeah.
Oh,
appreciate that. I was double muted. Apologize. Can you hear me okay now?
Go ahead, please.
Thank you. Okay. So John Gray, registered pharmacist with Kaiser Permanente. Thanks for the opportunity to provide comment. We're not providing any sort of comment on our general position around technician ratios. I did just want to point out that related to the discussion around the pharmacist's ability to refuse supervising a second pharmacy technician, I think probably most board members are aware that that language already exists in 4115 G3, and it from our perspective, it's fairly robust language and fairly strong language, allowing the pharmacist to refuse supervising a second pharmacy technician. So just wanted to flag that we're not really sure that there's any additional language needed in that regard. Thanks for the opportunity to provide comment.
Thanks for the comments, Dr. Gray.
Next, we're going to hear from Stephen Gray. Hold on just a moment. We're sending you a request to unmute your microphone.
Thank you again. A couple of comments. First of all, if you look at the data that was just presented, the overwhelming majority was to go well past 1-to-1. I know they focused on 1-to-2, but if you add the 1-to-2, the 1-to-3, and or even the 1-to-4, you get an overwhelming majority of both management and staff pharmacists that believe that there needs to be an increase. And if you think about it, it really is weighted to more than just 1-to-2. Keep that in mind. Second, I'm sure that some folks don't realize that physicians have medical assistants who do a lot of very important tasks in medical office, and there is no ratio. There is no ratio for physicians or limits on the number of medical assistants. And they have other people in there that they supervise. They have nurses. Some of them have physician assistants and nurse practitioners and many others. So why are we going to put limits on the professionalism and the decision-making of pharmacists? The other thing I'll comment from my history, I used to be the compliance officer for over 300 pharmacies in a large organization. And I would constantly visit those pharmacies, and I would find pharmacists that were not actually performing pharmacist duties. They were standing behind the counter with a spatula in their hand, counting pills and capsules by fives, putting them in a vial, attaching the label, and then handing it out to a clerk to sell. I asked them why they were still doing technician work, because those are the tasks that are clearly allowed, encouraged for technicians. And they said, 90% of them said, I'm not comfortable talking to patients. That was their excuse year after year after year. And the board yesterday wants a strategic plan to increase consultation. What we found is if we kept the pharmacy to technician ratio at the maximum that was allowed, that freed up the pharmacists to do more time with consultation and to find pharmacists and hire pharmacists that would take on that responsibility willingly and do a good job at it. So increasing the ratio should have that benefit as well. And again, why are we putting such limitations on pharmacists and their professionalism? We're talking about going to standard of care, hopefully today and in the future, and yet we're still going to put an arbitrary limit on the number of people they can supervise. Thank you very much. Bye.
Thank you for the comments, Dr. Gray. No relations to Dr. John Gray.
Next, we're going to hear from Scott Young. Hold on just a moment. We're sending you a request to unmute your microphone.
Animal policy group. So most of our pharmacies are closed door mail order pharmacies. So just two comments to the board. We don't really support a single tech ratio. I don't think there's just too much variety amongst the pharmacy profession for one ratio to really fit. So we definitely recommend a tiered approach similar to Florida, where you got different ratios for different types of pharmacies. Otherwise, we also recommend some type of waiver process with the board, which I know has been recommended previously. We strongly support that. Again, our pharmacies are closed doors. They don't compound. They don't carry controlled substances. So we'd like to make that argument with the board to allow us to expand the tech ratio. So yeah, definitely support the comments about giving the board a little bit more authority to provide flexibility to the variety of pharmacies that are out there. Thank you.
Thanks for the comments.
Next, we're going to hear from Alan Kim. Hold on just a moment, Alan. We're sending you a request to unmute your microphone.
Represent Cardinal Health, and I wholeheartedly support the board to make this long-awaited increase to ratio. But like the previous callers ahead of me, such as Dr. Yoshisuka, for those pharmacies that are closed-door pharmacies, there should be some form, if this change is made, there should be some forms where these closed-door pharmacies where we have no customer or public access, such as home infusion or nuclear or some of these compounding pharmacies, to have some type of a waiver system for us to not have that exact ratio. Thank you.
Thank you for the comments.
Thank you. And now we need to back up just a moment. Rosie Jadidian made a comment that was missed earlier. Rosie, we're going to give you an opportunity to speak. We're sending you a request to unmute your microphone.
Earlier session around the technicians when you guys made the changes. So I'm good. Thanks very much.
All right, thank you. And those are all of our requests.
Thank you, David. Okay, I know Jessie just has joined, and I believe I just want to make sure that she has some opportunity to say, but just keep in mind that if someone else just raised their hand, I think Lori. So we'll go to Lori. I think just raise their hand. I know I need to go take a break for people to use a restroom and stuff. So David, I think we got to have Lori speak, and then I'm going to open it for Jessie, and I'm going to open it for public comment really quick, and then we're going to go for both.
We have Lori available.
Thank you so much. Apologize, I thought I had my hand raised, but I think perhaps the other discussion went on a little bit long. Lori Walmsley on behalf of Walgreens. Really appreciate the comments from the other prior commenters, and I agree. Pharmacy operations are changing, and there's lots of different types of pharmacies that exist today that didn't exist when it was originally contemplated. There's, in addition to some of the closed door pharmacies, I know you guys have a discussion later in your agenda around central fill pharmacies. Again, that's another example of a pharmacy where there aren't patients present, which would, not have the same levels of distraction and things like that as, for example, a community pharmacy where you've got phones ringing and patients walking up to the counter and those kinds of things. Another thing to contemplate that supports some of the conversations that Dr. Sandhu made earlier is the individual skill level of both the pharmacist and the technicians. Not every technician is the same. Not every pharmacist is the same. So looking for flexibilities that allow for the people that know the operations the best, that work in the environment on a day-to-day basis, I think is certainly a good potential solution. The other thing is this is an extremely timely discussion. If you look at what's happening with pharmacy school enrollments from across the country, in California is no different. Pharmacy school enrollments are on the decline, but that does not mean that the amount of work that the public needs to be performed by pharmacists is on the decline. So it's critical that the board look at what are the things that need to continue to evolve in the practice to make sure that services continue to be available for patients. And that way pharmacists can also provide more healthcare services like you're looking at with your standard of care proposal. So all of these things really tie together, and look forward to the discussion and look forward to potentially seeing some additional adjustments in California.
Thank you for the comments, Lori.
I believe we're finished with public comment.
Okay. Jessie, anything you want to add? You don't have to, but
Yeah, I just want to make sure that I understand the motion fully, and then also I know that I missed the statistics. So it sounds, based on what I'm hearing, like the non-management positions agreed that there should be an increase in ratio. Am I gathering that correctly?
you are gathering that correctly, and I will have Anne just reiterate the motion, as I know you have all the rights to vote on that. So Anne, can you just?
Yeah, I believe it's a motion to amend business and or recommend to the board an amendment to Business and Professions Code Section 4115 to increase the ratio to 1:2 in the community pharmacy setting, with the ability for a pharmacist to refuse to supervise that second pharmacy technician. And Jesse, the understanding was that should this motion go through, staff will be working with the chair to finalize the language before the board meeting.
Perfect, thank you. I think my final comment, just based on what pharmacists are saying they're comfortable with, I think the ability to refuse is really important. And I also agree with, I think it was Dr. Yoshizuka, who, we had kind of talked about this previously, about somehow granting the authority to the board to be able to change the ratio. I do think that the setting is different, and settings evolve over time too. I heard from feedback from a lot of closed door pharmacists about the ratio, and when you think that there's no patient interaction, there's a little less distraction in that sense from the pharmacist, so they may be able to supervise a little more. So I would be open to potentially adding some sort of nuance that would allow the board to kind of be flexible and be able to get that authority later down the line, so we don't have to go through this process each time.
Sounds good. Thank you, Jesse. With hearing these comments, Jason, would you like to amend your motion in any way just to incorporate the possibility of the board having the flexibility in the future?
Yes, President Ong, President O. I certainly would be open to amending that and granting the board more flexibility. I just don't know. I think that would take legislative action. Or
yes,
so
all this.
That's
yeah. Yes.
So if we could encompass that into this motion and bring it before the legislature, then I think requesting that flexibility would be a wise action to take.
We could mirror how it's written in the technician ratio for the institutional setting, which I believe it allows 1:2, but then the board can change that ratio. So if we could mirror that language, and we don't have to draft it as exactly, and we could have some sort of a text, but we could just consider that as part of the motion and consistent with the discussion, and have Ann and I can come up with the language for the full board meeting, if that's okay with you.
That I would like that to be my motion. Thank you.
Okay, thank you. I just wanted to take that opportunity since we're going to go to public comment one more time. So is that okay with you, Renee, for the second?
Yes.
Okay, perfect.
I absolutely agree. Mm-hmm.
All right, with that, we're going to open up for public comment one more time, and then we'll go to a break. Well, we'll vote and then go to break.
We are once again open for public comment. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. And our first request comes from Stephen Gray. Hold on just a moment. We're sending you a request to unmute your microphone.
Thank you again. I completely agree with the motion that is now on the floor, which is especially to give the power to the Board of Pharmacy to, by regulation or to adopt the proper ratio based on the activities of the pharmacy and meet the public need. I want to comment that the original, when pharmacy technicians were officially created, they were created and the ratio was set by the Board of Pharmacy. So the first regulations on ratio were actually promulgated by the Board of Pharmacy. And so the Board of Pharmacy had the power to determine the ratio by setting. That was then amended by statute at the request of outside parties that were concerned about the community pharmacy environment. So that's how we ended up with the language that is in the statute today, and the compromise that the statutes would set the ratio for community pharmacies, but the Board of Pharmacy had the authority upon request, it says, for an increase in a ratio in the institutional settings. So this is like deja vu all over again. And I think it is now timely and past overdue that we go down this road, and want to hope that all pharmacies would give this support, and for the reasons we've stated before. I also think that, as we mentioned yesterday, the COVID situation has taught patients to, in many ways, avoid visiting community pharmacies. And therefore, they do not have the opportunity to talk directly to a pharmacist. And so by hopefully increasing the ratio of more pharmacists will be out there talking to patients both before and after they get their prescriptions filled, to provide them with greater advice and counseling and monitoring and helping with their therapy. So I think that this will open the door to more pharmacists becoming more intimately involved with their patients, and the public then more appreciating the value of pharmacists assisting them with their care. Thank you very much.
Thank you for the comments, Dr. Gray.
And that was our only request this time around.
All right, with that, we're ready for vote. Renee, how do you vote?
Yes.
Thank you. Jesse, how do you vote?
Yes.
Thank you. Satinder, how do you vote?
Yes.
Thank you. Jason, how do you vote?
Yes.
Thank you. And I vote yes. The motion passes. All righty, we're ready for a quick break. It's 10:40. We'll return in 15 minutes. Well, yeah, 15 minutes and 10:55. 10:55. We'll see you all back. 10:55. Okay, it's 10:55. We'll take a quick roll call. Renee, are you back?
Yes, present.
Thank you, Renee. Jesse? Maybe she's not back yet. So Tinder, I see you. Tinder?
Yes, I'm here.
Jason? All right, we are gonna have to wait for these two folks, as we do not. Oh, there's
Thanks, everybody.
No
Jason
worries.
Weiss here.
Thanks, Jason. Jesse's still not back. I'm gonna continue as we are very limited on time. Next agenda item is 6, agenda item for a discussion and consideration of proposal to establish reinstatement of a retired pharmacist license. You may recall that following a request from the public, the board referred this item to this committee for consideration. Background information is included in the meeting materials. Just to summarize, public comment suggested that the board consider development of a step-down licensure process for pharmacists getting ready to retire. It was suggested through public comment that the board consider the approach used by Nevada. During our previous discussion on this issue, we considered provisions in Nevada's law that provide the pharmacist who has been registered with Nevada for at least 50 years is not required to pay renewal fees after that time. During our prior discussion and following feedback from members during the April board meeting, staff have reviewed additional provisions that allow for reinstatement of a license from an inactive status. It is staff's understanding that Nevada relies on the reactivation provisions when restoring a previously retired license. I see Jesse's back. Jesse, are you back?
I am. Thank you, Sung. Just wanted to announce that I'm back.
Thank you. Attachment 4 to the meeting materials include a copy of proposed amendments to Business and Professions Code Section 4200.5 that would establish limited provisions for restoration of a retired license. I note that the proposal as drafted is similar in concept to both the Nevada model, but also the current provisions in the board's law related to reactivating an inactive pharmacist license. Members, I have reviewed the provisions and am comfortable with this approach. I believe this is balancing of the concerns that the members had about the fiscal impact that may have of not renewing, not collecting renewal fees for members whose license been more than 50 years, also balancing that with the request from the public of some ways for pharmacists who are considering retired or retire to be able to come back to the practice if it's needed in about 3 years of time from that retirement. So I do believe this is a very common sense consensus approach, and wanting to hear your thoughts on it. Members? Anyone? Okay, Jesse?
Thank you, Sung. I think the proposed language is excellent. I really didn't have any notes at all, but just wanted to reiterate the license, the fee waiver that we had kind of discussed before. Just want to make sure that any fees waivers that we agree on, if we do, aren't put back onto other licensees. But I thought the proposed language was excellent. I didn't have any notes on it.
This proposal would not have any effect on the fees, and if they would have to pay the fees, renewal fees. And please correct me, that's my understanding, if they are reactivating the license.
Correct.
Sorry,
We are
Ann.
not waiving any fees in this proposal.
Great, thank
All
you.
right. Any other members?
I also would kind of second what was already said. Just that I think the language is very clear, and I think it provides a good pathway for a retired pharmacist to continue to work as a retired pharmacist or to get back into the workforce. So I don't have any changes or thoughts, but thank you.
Thank you, Renee, Satinder, and then Jason.
I agree with the Renee and Jesse has spoke before, and you, President O. I think I agree with the language. I'm okay with it.
Thank you, Satinder. Jason?
I have a few questions. 30 hours of continuing education, or not 30 hours, 30 units. About how long would that take for them to complete? And then this issue was brought about in trying to reactivate this population of people during the pandemic. Would the proposal that we have now been helpful in the pandemic? I'm not exactly clear if this accomplishes what we were trying to do here.
Thank you, Jason. I'm gonna actually, sorry, I think Trevor's back. So if David, you could please promote him. And 30 hours, Jason, I will boldly say that it's just the number was chosen because that's how many units of CE that's required for pharmacists, so that their license would be retired, but they would just continue to obtain that. So
So
30 units.
A unit equals an hour?
30 hours, yeah,
Great.
theoretically.
Okay.
Yes. And then secondly, I'm going to defer this to Anne, but I believe that the COVID had a lot of layers of it, but one of the layers is possibly there were some federal provisions that allow, I believe, some sort of, well, you know what? I'm going to let Anne speak on that because the words are very specific how they were allowed to do it. But I believe this would have still contributed to helping for any pharmacists that are retired, but we had a waiver at that time because of the declared emergency. So, Anne, do you want to add to Jason's question on the question 2 about if this proposal would have had any impact? Go ahead.
Oh, sorry. Yeah, this is Anne. So yes, Jason, currently under the law, there is no way to reactivate a retired license. You have to resatisfy all of the requirements for licensure. So what this proposal would do would be to establish a pathway to reactivate a retired license. The language is mirrored, which did not exist during COVID, and yes, would then have eliminated the need in theory for the COVID waiver, if that makes sense. The language is based on the requirements to reactivate other types of pharmacist licenses, so it's consistent with the board's current policy in this area. We are just extending that policy to also apply to a pharmacist license that has been retired.
Thank you for that clarifying information, Anne.
Thank you, Jason. Okay, we are, Trevor, we're on agenda item 6 of the retired pharmacist license. And with that, any other member comments or anyone wants to make a motion to committee recommendation to approve to the full board as drafted, or any other comments?
Sung, this is Jesse. I'll move to approve the language as drafted.
Thank you, Jesse. Any second for Jesse's motion?
I'll second.
I'll second it.
Oh, thank you, Renee. Thank you. Thank you, Jason. Thank you, Renee. Okay. With that, we're ready for public comment.
We are open for public comment on the motion. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand. And as a reminder to our mobile device users, you may need to hit the ellipses button, that's the ... in order to find your hand. We're going to take a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue with the motion?
Yes, please. Thank you, David. With the motion and second and public comment, we're ready for vote. Trevor?
Yes.
Thank you, Trevor. Renee?
Yes.
Thank you, Renee. Jesse?
Yes.
Thank you, Satinder.
Yes.
Thank you, Jason.
Yes.
Thank you, and I vote yes, the motion passes. Next is agenda item 7, discussion and consideration of compounding by pharmacy technicians outside of pharmacies. The next item for discussion was referred to the licensing committee from the enforcement and compounding committee. During this and other committee meetings, we have discussed the requirements for licensure for a pharmacy technician. By definition, pharmacy technicians work in a pharmacy under the direct supervision and control of a pharmacist. As a quick note, Federal Law Section 503A of the Food, Drug, and Cosmetics Act makes it clear that authority to compound a drug preparations is in part predicated on compliance with the USP compounding chapters. Also a reminder, USP General Chapter 797 describes the minimum requirements that apply to all persons who prepare compounded sterile preparation and all places where sterile preparations are compounded. This includes pharmacists and pharmacy technicians compounding in all places, including those areas outside of a pharmacy. During our last meeting, we considered a number of policy questions. A summary of the discussion is included in the meeting materials, but so I will refrain from going into the detail, but again, highlighting that the committee and the board noted it is board's role to safeguard the health and safety of the public, and this role is memorialized in Business and Professions Code Section 4008. Following our last discussion and consistent with our discussion, staff developed a proposal to amend Business and Professions Code Section 4115 to establish clear authority for pharmacy technicians to compound under the direct supervision and control of a pharmacist outside of a licensed pharmacy. Further, as proposed, a notification requirement would be established. I note that the notification requirement will assist the board in directing resources to those locations for inspections and inspectors. Members, I have reviewed the language and believe it is consistent with our discussion and direction. And welcome your thoughts, members. I know this is also a hairy issue, so never shying away from controversial topics. Us, the Board of Pharmacy. Jesse?
Thank you, Sung. I don't know exactly how I feel about this. I think the language is okay, but I'm just not sure how it will work. For example, if facilities, if this passes and facilities realize they do need a pharmacist, maybe they go out and hire it. Does the pharmacist realize at that point that they're responsible for notifying them? And then I'm just not sure how much authority a pharmacist working at one of these clinics will have over the actual day-to-day operations if they believe that things aren't operating up to compliance, if they don't meet USP 797 standards. And so I'm fearful that this is putting a lot of responsibility on the pharmacist who may not have control over the operations of the facilities.
Yeah, absolutely. And that I think that aligns with my concerns I had. But I think that my hope of moving forward is that at least this will attempt at minimizing bifurcation of the law that we currently have. And at this point, it's a complete wild, wild west in the world. And it almost incentivizes pharmacy technicians to give up their license to work in these places, or that they have no incentives or continuing to keep their pharmacy technician licenses. So I'm hopeful that this is at least an avenue of making a little bit of putting it out there that it is a responsibility of some sort of a oversight of those folks that are preparing these very, very risky compounds that could unfortunately result in a significant risk of harm to patients. So, Satinder, go ahead.
I agree with Jesse and also with you, President O, in terms of concerns about how much authority that the pharmacist will have. But I think I agree that doing this, at least we have a pharmacist who, if finds that it's a considerable violation and doesn't meet the criteria, have the ability to hopefully notify the board and therefore, escalate the issue before it becomes any bigger. If they find it that it's unsafe. I think it's moving in the right direction, not maybe the perfect solution.
Thank you, Satinder. And I think it's a similar concept as the pharmacist reviewing surgical clinics, doing self-assessment, and all of those. So I think it's just at least a step forward. Renee?
This is, I think, just like you said, it's a step forward. I think exactly as you commented before, at this time, there's only reports of where these activities are occurring. So perhaps then at least requiring a pharmacist to oversee any kind of compounding, and just also as a reminder, since you and I are also on the enforcement and compounding committee, but these also include, so of course we're very concerned about sterile compounding, which have the USP 797 requirements, but there's also non-sterile compounding, so USP 795, of which there's risks associated with that, not quite the same risk, but risk nonetheless. And then, of course, overarching USP 800 for hazardous drug handling. And I think we did hear comments from the public with concerns for places that are hiring technicians to make chemo in offices. And so there's patient concern for sterility, but there's also, employee safety for handling hazardous drugs. So there's it's a huge Pandora's box, but I think at this point, by, like acknowledging that a technician, it will be still a pharmacy technician compounding, not in a pharmacy, and with a pharmacist, because there's a lot of requirements there, I think is a step in the right direction.
Thank you, Renee. Trevor?
Yeah, I agree with this being a step in the right direction, and I'm in support of it. My question is more as regards to how it's implemented. So we get this letter about the compounding activities. What happens to it? Where does it go? Is it integrated into our current systems? What does that look like? So we get this information. Does it go into a file? I'm curious about what that looks like.
Thank you, Trevor. And sorry, Ann Sotogren. I'm going to, the camera should be not pointing at the empty room, but pointing at you guys, so we can all see you all there too. So, hello.
Hi, it is Anne again. Specific to your question, Trevor, about how to operationalize this, I do believe it can be pretty simply operationalized in that we can develop some sort of an interactive online notification process, similar to what we have for several of the other kinds of notifications, health registry, drug take back, those kinds of things. So I think we already have a platform that we can use. And then once this information is received, then we can use these notifications and take a risk-based approach to conduct inspections at some of these. We can use this. I think many members have referenced the fact that this is kind of a step forward, right? And I think that the notification piece will allow us to start targeting some of these areas, some of these locations to do inspections, similar to kind of the approach we're taking with like IV hydration and those other areas, and kind of get our feet, get a sense of what's happening operationally, and look for those opportunities to either provide education to improve the practices there, or or look to see if this goes beyond education and the board may need to take a second step to ensure patient safety.
And as it relates to the licenses of pharmacists and farm techs, is this something now where if a tech signs or goes to work for one of these places, is this something that they need to register on their license or to that extent, or is it just they can still just go and get hired at one of these places and the notification system will let us know about the area they're working in?
Yeah, so currently there is no notification. So we'll be developing that notification process. And I believe how the language is drafted, the pharmacy technician would not be providing that notification. It'd be the supervising pharmacist providing it.
Got it. Okay. Thank you.
Thank you, Trevor. Any other member thoughts? Anyone wants to make a motion as drafted, or will it need more work? Open for suggestions, comments.
This is Renee. I would propose a motion as drafted.
Thank you, Renee. Any seconds?
I'll second it. I'll second.
Thank you, Satinder. Thank you, Satinder. All right, before we go to public comment, any other comments? We can come back for it. Okay. All right, we're ready for public comment.
We have a motion on 4115. If you would like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. As a reminder to our mobile device users, if you're having trouble finding that hand button, you may need to hit the ellipses button, that's the ... and cycle through one of 3 different pages to find that hand. We're going to take just a couple more seconds before we close public comment. We're going to call on Stephen Gray. Hold on just a moment. We're sending you a request to unmute your microphone.
Thank you for the opportunity to comment. I also support this as a movement in the right direction. And I think that the issues out there can be easily underestimated. Federal law allows 2 types of practitioners to do extemporaneous compounding. That is not manufacturers. I'm not talking about outsourcing. I'm talking about pharmacists and physicians. However, out there in the real world, there are dentists doing compounding, nurse practitioners doing compounding. Other people have picked up on the idea of doing compounding, especially in, for an example, sports medicine and dermatology practices. Also in dialysis centers, there are not only is compounding of sterile solutions for peritoneal dialysis being done, but it's being done without a physician on site. In the past couple legislatures, there's been law that would mandate a physician to be on site, and that has been defeated both times. So that type of sterile compounding is going on under allegedly the auspices of a physician, but that physician is not necessarily on site. So I think this is very important. Board member Barker pointed out that it also involves non-sterile compounding. The first line of the California Practice Act says that a pharmacy can compound for doctor's office use. That was all about a dentist who compounded phenobarbital syrup to sedate children before he performed dentistry. He did that by sending them home with some, and he also did that by giving it in the office. He made a horrible mistake in terms of the phenobarbital concentration and killed several patients. Barbiturates are almost, overdoses are almost totally irreversible. So don't underestimate the importance of this is to both non-sterile and sterile compounding. I think this is a start. There will be instances where technicians just give up their license and continue doing what they're doing. There may be a lot of opposition to this from dialysis centers and others, but I think it's a good start, and I think the board should go forward with it. Thank you very much.
Thank you for the comments, Dr. Gray, and always thank you for your awesome histories of always stories that share with us. Thank you.
That was our only request for public comment.
Thank you, David. Okay, with that, we're ready for a vote. But before, I'm going to open up one more time for opportunity for anyone to comment. Seeing none, I'm ready for a vote. Trevor, how do you vote?
Yes.
Thank you, Trevor. Renee?
Yes.
Thank you, Jesse.
Yes.
Thank you, Satinder.
Yes.
Thank you, Jason.
Yes.
Thank you, and I vote yes. The motion passes. All right, moving on to next agenda item 8, presentation on central fill pharmacy models used in California. Thank goodness you all can stop hearing me talk for a while and let Janice talk. Today, we are continuing our discussion on central fill pharmacies. During our last meeting, we received presentation on the central fill models used by Albertsons and Walgreens. Thank you again to Dr. Rob Geddes and Lori Walmsley for presenting on the central fill models used by our respective companies. Your respective companies. It was very informative, and I also had the opportunity to tour 2 central fill pharmacies, including one used by the California Department of Corrections and Walgreens Central Fill Pharmacy. All of this information was extremely helpful and assisting in the committee and understanding the operations of central fill models, and in particular, understanding the diversity of the models. Today, we have the opportunity to receive a presentation by Supervising Inspector Janice Dang, discussing more information about central fill models currently in use in California. A preview of the slides indicates we will be learning about different types of central fill models used in California, and hopefully this will be helpful as we move forward with our assessment of this issue in our next agenda item. Janice, the floor is yours. Thank you, Dr. Dang. I don't hear. Is she in? David, I don't think Janice is promoted yet.
Working on it.
There it is.
Okay, can you hear me now?
Yes, we can.
Okay, great. Okay, so this presentation is based on the inspections that we've done recently on the pharmacies that we've identified as central fill pharmacies. So next slide, please. So current law right now is California Code of Regulations 1707.4, which are the procedures for refill pharmacies. The highlight of this code section, it allows refill pharmacies to fill both refills as well as new prescriptions. Pharmacies that are refill pharmacies either have a contract with the originating pharmacy or they are under the same ownership. In regards to the labeling of the container, the label is required to have and/or the information from the pharmacy, that's the originating pharmacy or the refill pharmacy. But they are also required to provide the patient written information as to which pharmacy to contact in the event they have any questions. The current law also requires that both pharmacies maintain accurate records of the dispensing information, and that the original pharmacy is responsible for compliance with maintaining the patient profile, providing the consultation, as well as providing the drug utilization review for the prescription. Next slide, please. So this is just a general overview of the movement of a prescription that gets referred to a central fill pharmacy. So it starts with the originating pharmacy on the left, where the pharmacy receives the prescription, they process the prescription, do the data entry, do the DUR. If it's a new prescription, it can, like I mentioned earlier, it could get referred to the central fill pharmacy. Otherwise, if it's a prescription that's originally filled at the originating pharmacy, the pharmacist would fill it, they verify the product, it's sold, consultation is provided, and then when the patient needs a refill, the request will go to the originating pharmacy and then referred to the central fill pharmacy. So in the central fill pharmacy, what we've seen is there's various systems where the prescription can be filled. So it can either be one filled manually or filled using an automated drug dispensing system. And so if it's filled manually, and most of the products that are filled manually are your single unit products, like your creams, your ointments, or inhalers. Those go through the manual filling process, where it's just like the originating pharmacy, where it gets filled and processed by a technician. The pharmacist, it gets labeled, the pharmacist reviews it, and then it goes through the shipping process. If it's getting filled by an automated drug delivery system, there's various types of systems that are used. Many of these central fill pharmacies use both a manual system as well as they may be using more than one different types of ADDS systems to refill the prescription. So what's different with the central fill pharmacy is the stocking of the ads. So if they're using an ADDS, generally what happens is the technician will select the drug, the pharmacist will verify the drug prior to it being restocked into the canister, and then the technician will empty the content of the manufactured bottles into the canisters of the ADDS. With some of these ADDS throughout the system, they either one will take pictures of the contents of the prescription, they may take the weight as well. And then at the end, the prescription the final product may or may not be verified by the pharmacist, because they have up front, when they were doing the restocking, had verified it. A pharmacist had verified it. And then it goes through the sorting process where it gets shipped to back to the originating pharmacy. The pharmacy receives it through a courier. The pharmacy will verify and check in the prescriptions that were refilled. They will place it in recall. It gets sold to the patient. And then the pharmacist there will address any consultation requirements or any questions that the patient may have. So next slide, please. So in the past, probably 4 or 5 months, we've inspected 6 pharmacies that were truly central fill pharmacies. Within the last week, we actually discovered 1 more central fill pharmacy. So a total of 7 central fill pharmacies are physically located in California. There are 2 in Northern California, 1 in Central California, and now 4 in Southern California. As to the type of settings that they fill these prescriptions, 4 they're servicing community pharmacy or retail pharmacies. 1 service correctional facilities, and 2 service the long-term care pharmacies. Next slide, please. So, okay. So this, I kind of categorize so that you can compare the difference between the central fill pharmacies that are servicing community pharmacies versus correctional facilities versus long-term care facilities. So the 4 community pharmacies that are central fill that have been identified as central fill pharmacies, they are currently, the originating pharmacies are located in California. However, these central fill pharmacies also fill or also have licenses in other states. In regards to the correctional and specialty pharmacies that we've inspected, they are only California. The originating pharmacies are only located in California, whereas the long-term care pharmacies, those 2 are, they have originating pharmacies in California, but they also have licenses in other states as well. What's really interesting is just looking at the average number of prescriptions dispensed by these central fill pharmacies. So they fill thousands of prescriptions. So in a community pharmacy in one day, they could fill anywhere from 10,000 to 13,000 prescriptions. For the correctional facilities, they fill an average about 7,000 prescriptions a week, and whereas the central fill, the specialty pharmacies, they fill about 1,000 prescriptions per day. In regards to pharmacies that are servicing long-term care pharmacies, they fill anywhere from 14 to 3,000 prescriptions in one day. When we look at the hours of operation, they did vary. So other than the long-term care pharmacy where they were the central fill pharmacy, but they also service their own clientele or accounts that were skilled nursing facilities. So they were a little bit different. They were 24 hours, 7 days a week, whereas the other central fill pharmacy, they were not 24 hours, but they were open anywhere from 5 to 6 days and sometimes 7 days a week. And what did they fill? If it was a community pharmacy, if the originating pharmacy was a community pharmacy or a specialty pharmacy or a licensed correctional facilities, they did both new as well as refill prescriptions. Whereas in the long-term care pharmacy, when it's specifically for the central fill prescriptions, they only did the refills for what they call their cycle meds. So what they mean by cycle is like, say, for example, depending on the contract with the skilled nursing facility, they will provide them a whole month supply on a specific day of the month. So if their cycle begins the first of the month, they will fill a 30-day supply starting with the first of the month for 30 days. Next slide, please. So keep in mind with the thousands of prescriptions that are being filled daily, we looked at the staffing of how many pharmacists and technicians are staffed at these locations. And so on the average, we would see in these anywhere from 5 to 10 pharmacists staffed throughout the day, and then anywhere from 8 to 20, 21 pharmacy technicians staffed as well. So, you look at the ratio of what it is in a retail pharmacy versus now when you're looking at the central fill pharmacies, the number of staffing, how many prescriptions that pharmacist is responsible for, as well as the technicians for filling, increases exponentially. Okay, next slide, please. So we're looking at the fulfillment process. So what type of packaging containers are being used? For the most part, it is prescription vials if they're for tablets and capsules. And then in the long-term care, as well as for the licensed correctional facilities, most of them will use the bubble cards. Some of the patients, or specific like the inmates, they may have what they dispense them in strip packs where they're like individual pouches that are connected that you could tear off one of the pouches. So in the correctional facilities, those pouches are generally for patients that they will keep the drug. They call it KOP, or keep on person. So as I mentioned, there's various different types of ADDSs that are used in these central fill pharmacies. So how is the inventory acquired? They will get it from their wholesalers, or for those that are using the bubble packs, they may be getting it from a FDA repackager. Types of medications dispensed, non-controlled drugs, and as I mentioned, manually, they would also fill unit packaging, such as your creams, ointments, and inhalers. The community pharmacy, the central fill pharmacies servicing community pharmacies, correctional facilities, and specialties were not dispensing controlled substances, whereas if it was a long-term care pharmacy and the routine dose was a controlled substance, they would be filling controlled substances, but not the ones that are needed. It's primarily the ones that are routine. Next slide, please. Okay, so as I mentioned earlier, so there are different types. Before I move on to comparing, keep in mind there are different types of different types of devices that are used in these central fill pharmacies. So as I mentioned earlier, you could have an ADDS that simply does just accounting, which is your Kirby Lesters. You could have these ADDSs that are the cabinet style, or they're like in a cabinet or in a shelving unit where you have multiple canisters that are either that it can possibly count, label, take pictures and so forth of the container that's being, the prescription container that's being filled. And then you have these ones that are more modular, where they're like, they look like a pagoda kind of, where they have a large robotic arm that will do the dispensing of the vials as well. In addition, which I didn't include in this slide, instead of having it in a cabinet style, some of these central fill pharmacies will have throughout the warehouse or throughout the pharmacy, the canisters that are more in a an assembly line, where the drugs will, where the prescription container will move to where the canister that has that drug, and then it fills it. So instead of it being in a box or in a cabinet, is more spread out throughout the pharmacy or the warehouse. Next slide, please. So methods of dispensing, as I mentioned, there's a, these central fill pharmacies generally have more than one type of method of how they're filling or refilling these prescriptions. The technologies there, I listed the different technologies that we've seen that's out there, and you can always go onto their website if you want to see exactly what they look like. One of the issues is the maintenance of these ADDSs. A lot of them, they're operate by two ways. One, when they're in the canister, there's either high pressure that will press out the tablets through air and counting the tablets, or it's dropped. The canisters is specific to the shape of that capsule or tablet, and where it will drop and there's an electronic eye that will count the tablets or capsules dropping to fill the prescription container. So because of when we're talking about maintenance, one of the important parts is that they maintain the lens of the electronic eye or the electronic eyes that's pressing the air, maintain it to make sure it's cleaned. And then in regards to tracking of the drug or the prescription as it's being going through the whole process, if it's the type of warehouse, if it's their system where it's more going down a conveyor belt, a lot of those, the central fill pharmacy will use what they call a puck, where the prescription vial sits in the puck, and under the puck is an RFID tag. So you could tell through the RFID tag where in the process that prescription is being where in the process the prescription is. Whereas majority of them will use a barcode system where it will read the barcode for you to determine where it is in the process. So next slide, please. So in regards to the restocking process, as mentioned, in general, in all of them, the pharmacist will verify the product that is selected by the pharmacy technician before it is placed into each of these canisters for the ADDS to dispense the drugs. The restocking of the canisters are required to be labeled, but what we're seeing is that they are only they only have a label with the barcode and not necessarily with the drug name and strength. Next slide, please. Okay. In regards to the labeling of the prescription, it varied between the different central fill pharmacies. So with the community pharmacies, that's the originating pharmacy, they generally had the originating pharmacy's information on the label. For the central fill pharmacies servicing the prisons or the correctional facilities, and they had the central fill pharmacy information on the label. The specialty pharmacy again had the originating pharmacy's information on the label, and the long-term care pharmacy had their central fill pharmacy information on the label. So they varied based on the type of ADDS they use. in the community pharmacies, we saw that they were taking actual pictures from the bird's eye view of what the contents of the tablets or capsules are in the vial. Some of the system also weighed the product based which it may or may include the container with the drug or the container with the drug with the paperwork. And then versus with the correctional facilities and the long-term care facilities, they did not take pictures or weigh the product. Again, everything was more based on using the barcode. Now, what was interesting is pharmacists did not always perform the final check. We saw a variation where if they, where there was a pharmacist that was, doing the product verification after the picture was taken or after it was weighed, the final product was weighed. But there we did also see situations where there was no final pharmacist verification of the prescription. And so as the drug was getting dispensed, it would automatically, based on the barcode, would drop directly into the totes where for each of the designated facilities that it's going to go to, or the designated pharmacies where it's going to go to. So which pharmacist is listed as the dispensing pharmacist? It would vary. So if there was final check by a pharmacist, it would be that pharmacist initials going on to as the final pharmacist verification. However, if there was no final product verification by pharmacist, it would be either one, the designated pharmacist for the day, who's considered the dispensing pharmacist, or the pharmacist who's doing the verification up front prior to the ADDS being restocked. Next slide, please. In regards to packaging and shipping, again, a lot of it was based on using the barcode to determine where it's going, which tote it's going to go to which pharmacy. The containers, they use various types of containers. They could have used a tote that's sealed. Some of them will actually do a mailer and then it gets mailed back to the central fill pharmacy, and then they use, or like in the long-term care, they use these canvas security bags that are lockable. The couriers that they were using, which is what's interesting, is they had contract with their drug wholesalers that did the delivery of their central fill drugs to the different pharmacies. Versus for the long-term care pharmacy that which were the central fill pharmacy, they use their own drivers. And as I mentioned earlier, a lot of the central fill pharmacies for the long-term care, they have their own clients or their own skilled nursing facilities that they service. And so they would do their own delivery, their drives would do their own deliveries. However, if they were filling prescriptions for other pharmacies, then the driver will deliver it to the originating pharmacy, and the originating pharmacy will use their drivers to deliver it to the different skilled nursing facilities to the patients. So that did vary. And again, like I mentioned, the barcoding system was pretty much the main method of where they would track where the drug is located. Okay, next slide, please. So when it gets received by the originating pharmacy, the originating pharmacy will generally scan the totes as well as scan the individual drugs that they received to confirm that the drugs were received at the originating pharmacy. With the skilled nursing facility, I'm not sure. I know that the totes were scanned, but the individual drugs themselves, I do not believe that they were scanned at the skilled nursing facility or at the originating pharmacy to confirm that the drugs were received. They primarily scanned the totes itself. Okay, so next slide, please. So in handling these prescriptions by the central fill pharmacies, if there was a medication error, we looked at who handles the medication errors. So for the most part, the type of errors that we saw with the central fill pharmacies vary between the type of setting. So if it was a community pharmacy, if they were servicing community pharmacies, there were generally wrong drug, wrong quantities. Wrong quantities seem to be the #1 type of medication errors reported. With the specialty and the long-term care pharmacies and the correctional facilities, if they're using the bubble card system, it would be the packaging itself, where you may have in a bubble no capsule or tablet, or you may have more, if it's supposed to have 1 tablet in each bubble, it may have more than 1 tablet in the bubble. So that was kind of like the difference type of errors that we would see. For the most part, if there was an error, it was reported to the originating pharmacy. So when the patient picks up their prescription at the originating pharmacy, they would get the call. And then if it was resulting from the central fill pharmacy, it would get relayed to the central fill pharmacy, who would investigate the error. And who documents and reports it to the board would vary depending on their policies and procedures. Next slide. So that is pretty much in a nutshell what goes on in the central fill pharmacies.
Thank you, Dr. Dang. Thank you so much for the presentation. Understanding the different uses of central fill models is very different as we continue our evaluation of the board's current regulations. Thank you again to you and your staff for all your work in preparation for the presentation today. Members, do you have any questions or comments for Dr. Dang? It may be best to, we can incorporate this for next discussion, but if you have any questions from the presentation, feel free to speak up. Renee?
Hi, thank you, Dr. Dang, for the presentation. Very detailed, and a lot of new information for me. Kind of in light of some of the proposed change to the amendment that's proposed, has the phrase at the end. It talks about that the whole thing reads, "A pharmacist shall not be required to perform final product verification," blah, blah, and it says, if where product verification by a pharmacist performed at the time of stocking, which you spoke about here, the automated dispensing device, but then there's also the last phrase, if the dispensing device is not further accessed by pharmacy personnel. So, I have some questions about that statement, but from your perspective, since you were able to observe, how is that managed? How is it guaranteed? How do you guarantee that the dispensing device was not further accessed by pharmacy personnel?
So how can I say? So it's kind of interesting because not all systems have a final verification pharmacist. On some of them, they don't do any. Some did some, and so did the product verification, and one did a random sampling of 2% of the final product. Now they're saying that it's a system where it's consistent, that the access to the canisters are limited to, at the very beginning of the process. And they're claiming that, the way our law is written is that the pharmacist has to verify the work of the technician. So that's why they are upfront verifying the work of the technician prior to the restocking. The systems are very, very high tech, where you can always follow based on the barcoding and the timing when it was barcode at different steps, if there was any delay, I guess. But like anything else, there was some system where they did have like a reject button, where if it was rejected, then it required the pharmacist to definitely verify. But there were instances where you could possibly, if you ignore those warnings, it could go through the system without being verified again. So I can't really speak that 100% that everything, up front, if there's how can I say, if there was an interruption, if it would compromise what is being dispensed without having a final pharmacist verification. I know when the final product pharmacist, when the final verification pharmacist is looking, what they're essentially doing is just looking at the bird's eye view of the tablets that are in the vial. They're not physically counting, but they are, you know, like I said, they are doing some weight of what the final product is. Part of the problem with the final product, when it's just weighed with these tablets that are in capsules that are very small or light, it's hard to determine if it's accurate, because when we looked at the medication errors of, you know, majority of them were wrong quantity, where they were off, not just, you know, anywhere from 100 to 100 tablets, because again, some of these systems will marry up. If the drugs had to be in more than one container, they could be in multiple containers, and not all the multiple containers are collected together when it goes to the central fill, to the originating pharmacy. So again, what the final verification pharmacist is doing is essentially just making sure that it's the right drug based on a library of a library of pictures of what the tablet or capsule looks like.
Hi, this is Anne. Sorry if I
Yeah,
can just jump in for just a second. So, so not my area of expertise, but when have I let that stop me in the past, right? So, Renee, I think that there are some different types of, I'm going to use the word incorrectly, but some of the technology that is used, like once the canisters are, put into the device, they cannot be accessed again unless there's like a key and a supervisor to like reopen it. Not everybody continues to have access to it. I'm not quite sure if I'm hitting the mark there, but I have seen where there's been controls in place, part of it as a function of the technology, that once like the big canister is loaded, it can't be accessed again.
Thank you. Just was trying to get some clarity on how somebody would know.
Yeah, I mean,
It's our proposed amendment.
Yeah, it's interesting because it's very high tech. And so if you were to remove that canister, it would record that the canister was removed. So again, if it's removed, it will require some verification before it gets restocked back into the system.
Thank you, Dr. Day.
Yeah, thank you.
Thank you, Renee. Jesse, your hand is up.
Yes, thank you. And thank you, Dr. Dang, for the presentation. This helps my understanding a lot, and you did a really great job organizing this. I will say I'm surprised that not all pharmacies or pharmacists perform final verification. I do have a little experience with some of these machines. I've experienced knowing that, if there's a capsule, for example, that's a little bit clear, that some of the machines can't register that, and that's when you have the wrong quantity coming, or there can be tablets that get stuck in various areas. So kind of emphasizing that the cleaning and maintenance of these machines are really important. I'm curious to see, I don't even know if you have more information, but just in terms of the med errors, especially for blister packs, it's saying that the wrong quantity is the common med error that occurs. I will say I have experience with family members who have left psychiatric facilities with blister packs, and I happened to be home with them at the time of discharge, and I was able to identify that some of the medications were missing for the first day of the dosing. And if I hadn't been there as a pharmacist, they wouldn't have known. And so I'm curious if you know how errors are identified. Is the responsibility on the patient or on the people working in the facility, like nurses who are administering, and to identify if there's, if medications are on the wrong place, the wrong time of day, for example, and what extra quality assurance is in place so that these can be identified? Because I have a hard time envisioning that a lot of the patients who do need these services will be able to identify if they're getting the wrong product.
So in the central fill pharmacy itself, there were some, not all, where they, based on the weight or how the system sees the product, I guess. So for example, the bubble cards, there was a system where if it detected a bubble missing any tablet, it was smart enough to identify there was a bubble missing, I mean, a tablet missing in a bubble, and it would have a reject. And so they would have a warning that pops up, or they would have, it actually kicks it out of the system. It drops it into a different bin where the pharmacist physically has to verify it. Now, majority that are in a prescription container, like I mentioned, the number one medication error was quantity. And so the quantity generally were identified at the original pharmacy by the complainant, I mean, the patient itself. So the patient would complain that they're missing a container where they should have 3 containers for their 300 tablets, or they would say, I'm short 10 tablets. And so then it would be more the consumer that is identifying the quantity being incorrect to the originating pharmacy. Now, when it came to the bubble cards, and as you mentioned, again, it would be the nurse at the correctional facility, or it would be the nurse at the skilled nursing facility that would again notify the originating pharmacy that they're missing a tablet, or they're going to be short a tablet, or for whatever reason. So again, they have, the error is identified in, either by the pharmacy through their ad system, or by the consumer, or by the person administering the drug. So it's all 3.
Perfect. Thank you. That helps. In the case where I identified there was something wrong, it appears that whoever had entered the prescription in, the data entry point was where the error had occurred. And so the data, it was verified incorrectly, and therefore by the time it got to the blister packing, I'm not sure what kind of system they used, but it seemed to have been correct. But if I hadn't compared the dose and each tablet day by day to the discharge papers, they would have never been able to identify the error. And so I was just curious all around it. It seems like there's, I'm just kind of processing it all, but it seems like there's a lot on the consumer and the nurses, but this is all good information. So I really appreciate you taking the time to put this together for us today.
Thank you. Thank you, Jesse.
Yeah, so keep in mind also, it's the original pharmacy that is entering the prescription and doing the DUR. So once it gets to the central fill pharmacy, they're not doing that.
Thank you.
All right. Any other member questions before we open up for public? Oh, Satinder, go ahead.
So I have a couple of questions. Thank you for putting this together, Dr. Dang. This is very informative information, and the staff trying to get this, all of us upskilled on this. My question is, the facilities that you inspected, did you have any place where the upfront data was being reviewed by the originating pharmacy? And the second question is regarding this amendment, that there's a number 3 that says the notification paperwork. I was just wondering if that could be, instead of like creating all this extra paperwork, could it be also included so that it could be added onto the label, for example, where the prescription was filled or who filled it, so on, that for the consumer? I think it's important information, but could there be another ways that could be communicated? That's all I have.
When you say information or notification, are you talking about currently with the refill pharmacy, that if it's going through to a central fill pharmacy, that the consumer has to be notified if they have any questions? Is that what you're talking about, notification?
Sorry, I kind of confused that. That question was more of for the amendment that's proposed, that's on there. It wasn't necessarily for you. I was just, for you, the question was that upfront verifying pharmacist, was that ever at the originating pharmacy? And also, actually, I'd also like to add for you, with your experience, did you find those errors to be higher in these settings than let's say that in a community, if the prescription was dispensed in a more traditional way, like for a community pharmacy or outpatient pharmacy, or by the long-term care facility where the pharmacist has the manual check? Did you find the errors to be higher in those settings from your experience?
So when we ask them, what's your percentage of medication errors, based on the high volume, like I mentioned, some of them fill 10,000 to 13,000 prescriptions in one day. They will say that their percentage of error is less than 1%. But that 1% could be, several prescriptions, not just one prescription. And so, it's kind of hard to quantify if there's more errors occurring in central fill versus I don't know what the percentage is when it comes to retail pharmacy. So that's kind of hard to answer. But I know with the central fill, we will ask them, what percentage, and they'll all say it's less than 1%. Now for notification, I'm still unclear with that one, but up front, again, the pharmacist who is verifying what's getting restocked, they do not do another DUR or review of the profiles or anything like that. It is all done by the originating pharmacy. And again, it's the originating pharmacy that is required to notify the patient if there's any problems or questions, that they're the ones to convey that to the patient.
Thank you.
Thank you, Satinder. Any other questions? We'll have a lot more to ask Dr. Dang, I'm sure, as we ponder on the text. So, Dr. Dang, thank you again. And as a public agency, the committee provides members of the public the opportunity to comment on each agenda item. And this is not intended to be a question and answer, but rather an opportunity for members of the public to comment on the information discussed. At times, questions are asked. Dr. Dang, you are under no obligation to respond to questions if they are asked. However, we do ask that if a member of the committee requests a response, you are comfortable doing so. So with that, member, we're opening for public comment.
We are now accepting public comment via WebEx. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. You may also type the word comment into the Q&A box in the lower right-hand corner of the screen. And for our mobile device users, if you're having trouble finding that hand button, please hit the ellipses button, that's the ... and search through the 3 different pages to find your hand. We're going to take just a few more seconds to see if we have a request for public comment. We're going to call on Stephen Gray. Hold on just a moment, please. We're going to send you a request to unmute your microphone.
Thank you for the opportunity to comment. I strongly support the proposal to continue to allow central fill pharmacies in California. I had the opportunity to open the first central fill pharmacy in 1996 in California. In fact, probably from a civilian point of view, it was the first one in the country. And it was originally for refill prescriptions, just because that was easier to start with. At that time, we shared with the Board of Pharmacy our plans, that they even visited the pharmacy. They asked to keep track of error rates. We had detailed information about all the error rates in our community pharmacies where prescriptions were filled manually, because Kaiser was committed to fairness and also obligated under union contracts to what is called just discipline. So we knew the error rate of every pharmacy in Southern California where this was opening up. What we discovered was that for the refills in the first 6 months, the error rate in our local pharmacies was 1 out of every 40,000 prescriptions that a pharmacist refilled at a local level. That was the average. The error rate in the first 6 months for the central fill pharmacy was 1 out of 4 million. and that was verified by several entities. And the reason for that is the use of the technology, the barcoding, the 3D color pictures, all of that was described very well by Dr. Dang. And so the Board of Pharmacy at that time wanted to encourage that for a variety of reasons. One is that it allowed our pharmacists at the local pharmacies to do much better job at prescription consultation and reduce the confusion and so forth. And the error rate actually went down in local pharmacies. So I would strongly encourage you to go forward with this. I think that we'll discuss the language a little bit later, but I think that this is a good compromise and should go forward. Thank you.
Thank you for the comments, Dr. Gray.
And that was our only request for comment.
Thank you. Thank you, Dr. Dang, again. I believe your presentation has helped to further inform the committee, and we are ready to move on to the next agenda item. Dr. Dang, I'm hoping that you can stay, as we will definitely need probably some questions for you. Agenda item 9, discussion and consideration of proposed amendment to California Code of Regulations, Title 16, Section 1707.4, related to central fill pharmacies. As we have noted during our prior discussions on this topic, Strategic Objective 1.2 calls for the committee and the board to consider and pursue necessary changes in the law regarding various pharmacy practice settings to ensure variances in the practice are appropriate. As discussed during the prior agenda item during our January licensing committee meeting, it was suggested that the committee receive presentations on central fill pharmacies to aid in committee in its policy-making activities. Through the presentations, we have gained a better understanding of the central fill model and variances in operations. Provided in attachment 7 to the meeting materials is proposed regulation language previously considered by the committee that also includes a few additional changes for consideration. These changes specifically related to provisions surrounding final product verifications. Given the presentations that we received today, I'm hopeful members believe we have sufficient background information to resume our discussion on the proposed changes to the regulation text. As a reminder, this discussion was initiated in part of the request from the stakeholders seeking clarification on the board's current requirements. To facilitate review, I thought it may be helpful for me to summarize some of the proposed changes that are intended to clarify the current regulations, where some comments have suggested the language is not clear or have sought guidance on how to interpret or implement the language. First, throughout the language, you'll note that reference to refill is being removed. The prior language appeared to have conflicting language causing confusion about the ability of central fill pharmacies to fill new prescriptions. Members, I'm very comfortable with the change in concept and wanted to make sure everyone feels the same. I'll take the silence as an okay. All right, next, the first proposed change. Oh, Renee, go ahead.
Well, go ahead then, and I have a comment for later in the.
Okay, sounds good. The first proposed change in 1707.4.a seeks to clarify that both the central fill pharmacy and the other pharmacy are both licensed by and operated within California. I believe this is providing clarity only as the existing language of the regulation specifically includes a term within the state. I note that the public comment has suggested that we should not limit these provisions to pharmacies located in California. But I believe that would be an expansion to our current regulation, and I would strongly urge we maintain California requirements. Members, appreciate your comments. Silence as an agreement, I would hope. Okay, all right. Next, the proposed change in 1707A2B is intended to clarify that the originating and central fill pharmacies have the flexibility to include the name and address of both pharmacies if they so choose. I believe the clarifying language is appropriate and provides flexibility. I would note that the pharmacy identified on the prescription label would need to have sufficient staff and have access to all information necessary to assist a patient. Any comments on this, members? Doesn't sound controversial. Jesse, go ahead.
Hi, definitely not controversial. I'm just reading this and I read it almost exactly the same as the language that existed previously. I'm not sure if anyone else kind of read it the same, but I don't see much change. It sounds like we're just kind of rephrasing it. I don't know
Probably
if anyone kind of agrees with that. For me, it doesn't provide much clarity. I mean, I'm fine with it either way. If people think that's more helpful, I'm just not sure that the change is necessary the way that I read both of them.
Thank you, Jesse. Yeah, I think it's just adding clarity. Yeah, absolutely. All right. Next proposed change is in 17074A5. This would establish a permissive requirement for the originating pharmacy to perform final product verification prior to dispensing, and allows for the final product verification to be done by viewing photographs in lieu of a physical visual inspection. I expect this is where we may receive the most comments. Based on the information learned through the presentations, I believe there may be opportunity to leverage the safeguards in place through the use of technology, and perhaps provide some flexibility to pharmacists to evaluate if they believe the final product must be verified under specified conditions. So here we are. I'll open this up. Go ahead and share your comments, members. Anyone? Renee, go ahead.
Yeah, this is where I was just trying to get clarity with Dr. Dang's presentation at the point where it was being discussed about that a pharmacist verifies the canister. You know, I think this addition here, I'm just wondering if that last clause, if the dispensing device is not further accessed by pharmacy personnel, if it needs to be included, because I think that you know, and nobody's like, I think if they have as a process that a pharmacist does the final verification, then there shouldn't be access by pharmacy personnel by definition. And so if there's safeguards in the device, in other words, like it sounded like what was explained was, you know, like possibly they have only a pharmacist would have a key or a code to access that canister, then it seems like it maybe doesn't provide, because of that clause, it seems like it may not provide the ability for the final pharmacist to not have to perform a final check. I don't know if I said that too many negatives, but you know, because at the very, you know, just having that, if the dispensing device is not further accessed by pharmacy personnel, I feel like somebody's got, that seems to be implied by the pharmacist has the final verification. So I would assume that in their process, in the way the technology is built with safeguards, that the access or the closure of it, however that might be, would be without, I have never seen these things, so would be that a pharmacist would have the final closure, documentation, electronic signature, that type of thing. So that's my only concern with that last sentence. I'd be curious what other people say or in public comments.
Thank you, Renee. I would be supportive of striking that out as well. And I think that needless to remind everyone here that this is the just a committee recommendation to possibly change regulation, which probably will take 2 years. So, all right, Jesse.
Thank you. I would actually leave it in just to make sure that that's actually in place. In my experience, most of the dispensing devices I've used do require a pharmacist, but I'm not sure if that's like a technology thing, if that was a facility specific protocol. And so just to ensure that no other pharmacy staff or personnel would be entering the automated device in between that, I would probably leave it in.
Thank you, Jesse. Any other thoughts, members? Anyone have any motion to try to propose promulgating this regulation, starting this process through? But let me just cover one more thing, and that is the 17074B, which provides a definition of central for pharmacy. so that it's consistent with our prior discussion and is also consistent generally with the presentations discussed. Just also note that some of the written comments are suggesting that the board expand the definition to allow for central fill pharmacy to mail the prescription to the patient. I think that they are a little bit different model, and so I welcome your thoughts on that part as well. But anyone wants to make a motion? Because I think we're in general agreement to propose and proceed through this text change.
Sung, I will move the language on the screen.
Thank you, Trevor. And that is, which way are you leaning for the?
As opposed to be amended or consistent.
Sorry?
For the, just so that the record is clear, Trevor, would you mind reading the motion into the record and then just clarifying if you want the recommendation to include the language as presented or something different? Thank you.
Yeah, I mean, my focus was just going to follow Jesse's recommendation, just leaving it in for now, so it's there to be considered. So my motion is to recommend the initiation of a rulemaking to amend California Code of Regulations Title 16, Section 1707.4 as proposed. Authorize the executive officer to further refine the language consistent with the committee's discussion and to make any non-substantive changes prior to presenting the proposed rulemaking to the board.
Thank you, Trevor. Do we have second?
I'll second.
Thank you, Satinder. All right. With that, we are ready for public comment.
We are open for public comment on the motion. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. And our first request comes from Stephen Gray. Hold on just a moment. We're sending you a request to unmute your microphone.
Thank you. As stated earlier, I strongly support central fill. And based on many years of experience with both the efficiency of it, the accuracy of it, and how it allowed pharmacists to be better utilized for patient care at local levels. However, I believe that Section 5 of A needs to be modified. And that is because the fact that a pharmacist has checked it works very well for tablets and capsules where the label with its barcodes and patient identification have already been applied to the vial. And the pharmacist is just verifying, or the machine is just verifying what's in the vial through a weights or 3D color pictures, etc. But it is not acceptable for tubes of ointment, bottles of liquid, oral contraceptives, other things where the machine does not apply the label until after it has been selected from stock, usually by a pharmacy technician, and then the label is applied often by that pharmacy technician to those through those containers. Those should be checked by a pharmacist. So Section 5 needs to be modified to say that if the pharmacist does not need to check it, it's because the label into which the tablets and capsule has already been applied, which identifies the patient, the drug, and everything, and is verified by barcode, so that the machine knows exactly what should be put in each vial in terms of tablet or capsule. So I would encourage the motion to go forward, but I would encourage the chair and the executive officer and staff to make that modification because that's how these systems are used. The system I was responsible for was capable of filling over 100,000 prescriptions a night. And the accuracy was, as I mentioned, verified periodically. So, but that was one very important factor. There was still pharmacist final approval if it wasn't tablets or capsules that were put in a vial. Thank you.
Thank you, Dr. Gray.
Next, we're going to hear from John Gray. Hold on just a moment. We're going to send you a request to unmute your microphone.
Thanks very much. Good afternoon. This is John Gray, registered pharmacist with Kaiser Permanente. I'll give the caveat I've been giving throughout these conversations with the committee, and that is that currently Kaiser Permanente doesn't operate any central fill pharmacies in California. However, that's not to say it's not something we would consider in the future. And for that reason, we really appreciate the committee's deliberate and thoughtful approach to updating this regulation. And we want to particularly thank the committee for including language that addresses the conditions under which final product verification by a pharmacist need not be performed in a central fill pharmacy. We think that's an excellent addition to the regulation, and look forward to participating throughout the regulatory process. Thanks for the opportunity to comment.
Dr. Gray.
Next, we're going to hear from Mark Johnson. Hold on just a moment, please. We're going to send you a request to unmute your microphone.
Thank you very much, Mark Johnson with CVS Health. Our IT guys wanted me to comment in what appears to be a simple comment, but the word photograph is an outdated terminology, and they believe that the proper terminology would be image these days. They relate a photograph to old school handheld cameras, and that digital images are the proper terminology, and they requested a change in the language. Hopefully that's simple and not substantive. Thank you very much.
Thank you, Mark.
Next, we have Lori Walmsley. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Walmsley on behalf of Walgreens. I'd like to thank the board for your robust discussions on this and the educational efforts that that the board has undertaken to make sure that you really understand what these environments look like, since they are so different. In general, Walgreens is very supportive of the changes. I do agree with Dr. Crowley that the language specifying that with the closed loop system that it can't be accessed again, I do think that that is beneficial, because it is explicit that that type of technology is allowed. That is one of the key issues that we've had, is there really wasn't a good process for which it wasn't explicit enough in the rules that that was an allowed permitted process. So we do appreciate that. The one area that I think that there's still some opportunity to work on within the proposed language is around the patient notification piece. Most other states that have some sort of patient notification, actually all other states that have some other sort of patient notification requirement, allow for the use of signage. There are also requirements in some states around labeling, which you guys are including as well. And I do believe that that could be also considered patient notification. So I don't know that I think that the written notification prior is necessary. I don't think it's something that most patients would be concerned with. There's also language in some other states that allow for an opt-out process if the patient doesn't want it, if that's your choice. But just out of respect for environmental concerns and those kinds of things, I don't know that I think written notification, because that would potentially have to occur with literally every prescription that's filled in California. I don't know that I think that that's really going to serve a lot of benefit to the public, but appreciate the discussion, and I think the regulation is definitely moving in the right direction, and I will stop my comments there. Appreciate it, guys.
Thank you, Lori.
That was our last request for public comment.
Thank you. Thank you, everyone. I think with public comment, we are ready for vote. Trevor?
Yes.
Thank you, Renee.
Yes.
Thank you, Jesse.
Yes.
Thank you, Satinder.
Yes.
Thank you, Jason.
Yes.
Thank you. And I vote yes, the motion passes. Looking at us, making progress. Agenda item 10, discussion and consideration of licensure and other requirements for non-resident pharmacies. As I previously shared, I am Sorry, someone just popped up there. I don't know if, oh, never mind. I'm concerned about the board's inability to regulate non-resident pharmacies, including mail order pharmacies. Non-resident pharmacies can create unique challenges for patients. I can recall investigations that resulted in discipline stemming from these challenges, placing patients at risk. As I shared during our last meeting, over the last 2 years, the board has referred 11 non-resident pharmacies to the Office of the Attorney General and for formal discipline and issued 39 citations. In addition, the board took disciplinary action on 12 non-resident pharmacies. The underlying violations vary in egregiousness and include extremely serious causes of actions, including clearly excessive furnishing of controlled substances. As a reminder, there is currently no requirement for pharmacists working in these non-resident pharmacies and providing services to California patients to be licensed in California. As a quick reminder, the board has previously voted and will be pursuing a statutory change to require the pharmacist in charge of a non-resident pharmacy to be licensed in California. Today, we will resume our discussion and consider proposed amendments to Business Professions Code Section 4112, consistent with our prior discussion and direction. As I shared during our last meeting, I'm very concerned about the actions undertaken by some states to eliminate law and jurisprudence examinations, as well as recent actions by Michigan and North Dakota that allow pharmacists licensed in Canada to reciprocate licensure without taking NAPLEX. As the meeting materials provide background on our discussion, I suggest we focus our discussion today on the drafted language. You'll note that the proposed language would update requirements for pharmacists working in a non-resident pharmacy who are not licensed in California, as well as establishing provisions for mandatory inspections of non-resident pharmacies. I have reviewed the language and believe it is consistent with our prior discussion. I believe the language strikes an appropriate balance regarding pharmacists' requirements by ensuring that any pharmacist providing services to California patients meets the same minimum standards as California pharmacists without requiring licensure in California. Just want to highlight that there was a letter that was sent to all of us, as it should be posted also. I believe that unfortunately misunderstands our intent of the section of this proposed section. It's not a requiring licensure. This proposal does not require licensure. Well, I can have Corinne speak to it and confirm, but this section does not require licensure in California for non-resident pharmacies who have servicing patients in California. It is simply making sure that pharmacists who are working in non-resident pharmacies servicing California patients has had to pass NAPLEX, basically is the requirement. So just wanted to clarify that. Corinne, do you want to just chime in
Yes.
there?
Yeah, absolutely. Yeah, with respect, I believe that the letter that was submitted did misinterpret the language, and what you just stated, President O, is correct. It's not requiring licensure in California. It's just saying they're not licensed in California. They have to have passed the NAPLEX.
Thank you. All right, with that, members, any comments or thoughts on this proposal? Jesse?
Hi, thank you. I think the language is actually really confusing, and I can understand why the written commenter was confused. I think the intent is good, but I think we could probably still do some refining, specifically in G2. The way that's phrased, just as like a pharmacist reading, it sounds like they do have to be licensed in California. And so I'm wondering if if there's any way to rephrase that.
Yeah, if the policy level wise, if everyone is agreeable to the text, I think we can absolutely try to redefine that and restate that and to make it clearer. So I don't think that we are the experts at wordsmithing. So we'll just, if everybody's agreeable on the policy aspect of it, we could make a motion as to, probably amend 4112 as consistent with the policy directions and the discussions at the committee level, and then proceed forward that way, if that's agreeable. But I think hopefully it is, if everyone is agreeable to the intent of what this is accomplishing, which is first is making sure that the pharmacists licensed in other states are also at least passing NAPLEX, and the second, the non-resident pharmacies are inspected at least every 4 years.
Thank you.
Okay. All right. Any other comments before hoping for some motion here then? I think.
Actually, I do have one other comment under G1, where it says the pharmacist license has been revoked by the board. I'm wondering, is the board referring to the California State Board of Pharmacy? Because if the intent is that they don't have to be licensed in any other state, I think we maybe need to also rephrase the board to be clear that it's any state board or U.S. territories board.
All right, here we go again. Ann Sodagran, and Corinne probably more so, but I think it's all boards, but I guess it's not clear. So.
This is Corinne. I mean, generally when you see the word board, it's talking about the California board. So if there's additional, clarification that the committee wants to make on that, then you could give that direction.
Jesse, would you like to include that it is any board?
I would want to include that just so that we don't end up with a pharmacist who does have their license revoked any other territory.
Yep, that sounds great. Anyone wants to make a motion? A quiet bunch.
I move we recommend the board pursue statutory change to update the requirements for non-resident pharmacies consistent or as consistent with the committee's discussion.
Thank you, Trevor. And seconds for the motion.
I second that.
Thank you, Jesse. All right, with that, we're ready for public comment.
We have a motion and a second on the floor. We are accepting public comment. Please raise that hand by tapping the hand button at the bottom of the screen. Dial in users, dial *3 to raise a hand. And we will call on people in the order presented on WebEx. First comes Tennille Davis. Hold on just a moment. Tennille Davis disappeared. Next we have John Gray.
Thank you. Good afternoon. This is John Gray, registered pharmacist with Kaiser Permanente. Thanks for the opportunity to comment. Glad to hear that the committee chair and board staff will be workshopping G2, because I also read that to mean that the pharmacist at the non-resident pharmacy had to be California licensed. So look forward to seeing the workshop language on that. We do continue to encourage the committee to consider whether it is the best use of the board's resources to require inspections of all non-resident pharmacies every 4 years, or whether there are cases in which it would be appropriate to accept inspection reports from the home state's board, as many other states do, or a third-party organization such as NABP's VPP program. The committee could consider asking for a presentation from NABP on the VPP program to assess whether that would be an acceptable alternative to sending the board's own inspectors to the non-resident pharmacies to perform an inspection. And then lastly, I would just encourage the committee to think about the proposed change that was just discussed. That a pharmacist couldn't be involved, couldn't participate in the dispensing of a prescription to a California patient if their license had been revoked by any board. You can imagine a circumstance where an individual makes a mistake early in their career. You guys see these folks at your disciplinary petition meetings. They move to another state. The state that they move to sees fit to license that pharmacist, and they find employment at a pharmacy, and then to have them foreclosed from participating in dispensing within their home state to a certain category of patients, just seems to could be viewed as sending a message that you know, the California Board of Pharmacy doesn't believe in, you know, giving second chances to rehabilitated pharmacists, which I don't think is what you're trying to do. So I think that's all I have to say about this one. Thanks for the opportunity to comment.
Thank you for the comments, Dr. Gray.
Right, next we're going to welcome back Tennille Davis. Hold on just a moment. We're going to send you a request to unmute your microphone.
You called me and it must have made me go away for you.
Come back.
So I did submit the letter yesterday. I am Tennille Davis, the Chief Advocacy Officer for the Alliance for Pharmacy Compounding, and we did misunderstand the proposed language, and it does look like all non-resident pharmacists should have to hold a California license. I'm not in, if they only have to hold a license in their home state, I don't have a problem with that. So sorry for the misunderstanding, but I do agree that you guys should maybe workshop the language to make it less confusing.
Thank you so much.
Next we have Lori Walmsley. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Thank you, Lori Walmsley on behalf of Walgreens. Really appreciate the discussion and feel like this is moving in a much better direction than where the board started. Appreciate the fact that you're looking at not requiring licensure, but rather ensuring that certain standards are met. If the licensure was required, I do believe it would be a very large burden on many of the non-resident pharmacies and could become a public health access issue, especially for things like specialty pharmacy, compounding, as well as mail order services. So I look forward to seeing the workshop language and think that this is certainly a step in the right direction. I appreciate it.
Thank you for the comments, Lori.
Next we have Lindsay Gulahorn. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Afternoon, Lindsay Gulahorn here with the California Community Pharmacy Coalition. Just want to align my comments with some of the previous commenters. Thank the committee for looking into this and for the opportunity to comment. And our initial read also was that this proposal would require licensure for all non-resident pharmacists, which could be a big administrative burden, a cost issue, and could really harm patients if enacted, especially as mail order becomes more common. So happy to hear that that's not the intent of the language, and really do appreciate all the discussions and work on this, and look forward to seeing the revised language as this moves forward. Thank you.
Thank you for the comments, Lindsay.
Next we have Mark Johnson. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Hello, Mark Johnston with CVS. I echo the comments of my other the other folks that have talked today, so I'm not going to reiterate in the name of time. I did take one additional step, though. I contacted the Michigan Board of Pharmacy, and since this Canadian pharmacist allowance has existed in their state, which has been over 2 years now, they have licensed 36 Canadian pharmacists. The chances of one of these working in a non-resident facility in Michigan who would touch a California drug seems minuscule, and perhaps your resources are better used elsewhere. Thank you.
Thank you for the comments, Mark.
And potentially our last comment comes from Stephen Gray.
Thank you again. I understand the confusion about G subsection 2. I had to read it twice. It's kind of a double negative. If you start out by saying up in G, a non-resident pharmacy shall not permit a pharmacist, and then down at 2, you say the pharmacist is not licensed in California. But I understand what you're getting at. There are pharmacists who are licensed in California before 2004, when the NAPLEX became required, that are working in some non-resident pharmacies. So I guess what you're saying is they were licensed in California before NAPLEX was required. The question is, do they still have to maintain that license before and the license of the current state, or was it okay that they're only licensed by the current state because when they were licensed in California, they didn't have to take the NAPLEX? So I think that needs to be part of the consideration on how to clarify that. Thank you.
Thank you for the comments, Dr. Gray.
And that was indeed our last request.
Awesome. Thank you so much. Thanks, David. Okay, members, we're ready for a
Hey, Sung, this is Jessie. Sorry, I have
Jessie.
some additional comments after hearing some. I think it was
Yeah.
Dr. John Gray who mentioned under G1. I will say when I initially read that, my thought was that they currently have a revoked license, but I do think he brings a good point about rehabilitation. You know, if a license had been previously revoked in a state, but they have since reinstated the license through whatever that state's processes were. I don't think my intention was to prohibit that person from being able to work in a non-resident license. So I just want to throw that out there. And if all the other members of the committee are okay, hopefully the staff can kind of work to rephrase that to make sure that is clear as well.
Okay. You probably have to amend the motion possibly, Corinne?
The motion was per the conversation amongst
Yeah.
the board, so
Okay.
that should fit in
Are
fine.
we okay?
I think we're okay.
All right. Good to hear. Satinder?
Yeah, I agree. I agree with it, Jesse, regarding the including the language and make it clear that we're not excluding those pharmacists. And I think that also the comment about maybe we can include since California start accepting or NAPLEX, we can make some sort of a date included in the language so that from starting from that on, it doesn't,
Yes,
it would be great.
absolutely.
That's all.
Yep. Okay. Thank you, Satinder. All right. Looks like we're ready for vote. Trevor, how do you vote?
Yes.
Thank you, Renee.
Yes.
Thank you, Jesse.
Yes.
Thank you, Satinder.
Yes.
Thank you, Jason.
Yes.
Thank you, and I vote yes. The motion passes. All right, next agenda item 11, discussion and consideration of proposed amendments to pharmacy law to transition to a more robust standard of care model for some pharmacists provided patient care services. The meeting materials summarize relevant laws and regulations generally detailing the scope of practice for pharmacists. As we discussed during our April meeting, and as a quick reminder, as required by the board's last sunset review, the board was required to evaluate if moving to a standard of care enforcement model was feasible and appropriate for the regulation of pharmacy. The board, through an ad hoc committee, took a deep dive into the issue and ultimately concluded the board's current hybrid approach to the regulation of the practice of pharmacy is appropriate. At that time, the board noted that based on information received, California patients would benefit from pharmacists gaining additional authority to provide some patient care services consistent with their respective education, training, and experience. Any such change would require legislation. Today, we have the opportunity to continue our discussion on potential statutory language that could facilitate such a transition. Included in the meeting materials is draft statutory language that was prepared to assist the committee. To quickly summarize, the language would expand provisions for pharmacists to perform CLIA waive tests beyond those currently allowed in Section 4052.4, allow pharmacists to perform therapeutic interchange under specified conditions, would establish authorities for pharmacists to furnish FDA-approved or authorized medication that is preventative or does not require a diagnosis, and would expand pharmacists' current authority to administer biologics and would allow pharmacists to furnish an FDA-approved or authorized non-controlled medication for the treatment of minor non-chronic health conditions or for which a CLIA waive test provides diagnosis and the treatment is limited in duration. Would expand current authority for pharmacists to complete missing information on a non-controlled medication if there is an evidence to support the change. Would expand authority for pharmacists to substitute medications that are generally considered interchangeable. such as if insurance would cover only one medication but an interchangeable medication was prescribed, would allow for medication therapy management and adjust treatments to manage chronic conditions diagnosed by a prescriber to optimize drug therapy. As I shared in our last discussion, I realize for some this proposal may seem too expansive and to others it may not go far enough. I also want to highlight that staff included information in the meeting materials regarding California's DXF data sharing agreement. I highlight this as I believe it may provide a path forward in addressing some of the concerns expressed related to coordination of care with other healthcare providers and challenges with access to necessary medical information. I also want to highlight that consistent with the committee's prior discussion, language regarding liability has been incorporated. Would like to ensure that everyone received the comments from the California Pharmacists Association and recommending some additional changes to the language. And so I would appreciate your thoughts on their recommended changes, but also any other comments about the proposed text of the statutory change. Members, I'm sure you have some thoughts to share on this. Or it looks perfect, then it's great. Jesse?
Thank you, President O. So I'll start off by saying that I agree with all of the written comments by CPHA. I think all of the suggested amendments that they made make sense. And then I have a couple of notes for myself. So starting with number 5 there, I kind of mentioned at the last meeting about the interchange. I still don't agree with that, just from my own experience in the retail setting, not having all the lab values or the patient history necessarily all the time, and just my experience with some prescribers where they're adamant on using a particular product or medication. So it's one thing to change formulations because of insurance, but changing the medication altogether, particularly if you don't know the patient, maybe the patient doesn't fully understand why a doctor chose a particular product over another one. So I still am hesitant about that one. I also have a note for number 8. It says to prescribe over-the-counter medications, and this is more just a question for clarification, whether that's supposed to say furnish. I'm not sure.
Actually, it's very specifically trying to use the word prescribe.
Okay.
Very specific. And
So
the reason
number-
is actually related to the next agendized item, but go ahead. Yeah.
Got it. Let's see. Number 9, I put a note. This is just a grammatical thing, but I think that where it says patients and, we could probably just make that patient, comma, providing consultation to patients, healthcare professionals, and participate in multidisciplinary review of patient progress. Let's see. 10 is another one that I'm still on the fence about, just, preventative, just the vague language of it, I think makes me a little nervous because there are a lot of things that can be considered preventative, as we stated in the previous meetings. 17, oh, sorry, this is a lot. It says to adjust prescription treatment, drug regimen consistent with medication therapy management reviews for chronic conditions. So I'm not sure if that was intended to be, well, this whole thing is intended to be open, right? But when I think of chronic conditions, I also think of things like chronic pain. And so are we also stating that pharmacists are able to adjust controlled substances? And I know there are pharmacists who do have that that authority and have their own DEA, but just seeking for clarification on that one. And I think that's it. I know that was a lot, so.
No, not at all. I think that's a good comment. I would imagine that it's kind of a standard of care concept where the pharmacist has experience in dealing with that work. They would petition to go to DEA and get their DEA license and hopefully be able to do that if they're qualified and trained. If they're not, they should not do that, and they hopefully will not do that. And I hope that that's, the ideal setup that's created. And the prescribe was a very deliberative, that's just assisting with the concerns of third parties or entities that claim that
Payers.
we cannot, payers, we are not allowed to prescribe. So we're hoping that the people who are entitled to get the birth control, over-the-counter hormonal contraceptives, and other over-the-counter products, that they are able to try to be billed by pharmacists prescribing those medications. Go ahead, Sachinder.
So yeah, I agree that we need to have the prescribed language in there in order for to bill third parties, because without that, you wouldn't be able to process the prescriptions through a lot of the pharmacy systems and then to provide the billing and so on. So I think we need that language. And second one was a question. Generally, I would assume that the reason the language is expensive or a little bit vague is because of the care model instead of the prescriptive, just, defining everything and more allowing pharmacists to act as their judgment of sorts. So I assume that's why it's that way. Okay, that makes sense. Thank you.
Thank you. Any other comments? Hopefully we have a lot of comments. We're running out of time though, almost. So anyone wants to be bold and make a motion to propose possibly amending this standard of care model and moving forward as a consistent with the discussion of the committee? Anyone there?
This is Renee. So it's not actually about a motion, but I would agree with Jesse that I did appreciate the comments from the California Pharmacists Association. And so I'm just, like wondering how does some of that get incorporated? Does that need probably more discussion?
Yeah, we don't have to do the motion today. I think if you feel that the language could be redefined more, so we have a couple more committee meetings, so, well, probably one more that we could have this discussion. So we could try to incorporate, if there's any sections of the CPHA part that we're all agree. I don't know if I would agree 100%, but in general, I'm in agreement with what they are hoping to accomplish. But I also want to be mindful of, we don't want to create a lightning rod in the communities of all other licensing boards. So I just want to be mindful of that. So anything from the CPHA letter that you really would like us to focus on so that we could try to amend some proposal for next meeting, please let us know here. Or is it all of the above? Then that'll be a daunting task for us, but we'll.
Yeah, it's not like 100%. I'm just wondering, because Jesse had made the same comment, but I'm wondering, that she also agreed with however she actually worded it, whether she agreed with all or a lot of the comments. But I'm just wondering, like, what if we incorporate some, which ones, when?
Yeah, is there anything that you feel is your priority, Renee, among the comments that they're submitted by CPHA?
Let me review again.
Yeah, I'll start
Or
to
Jesse.
kind of go through it too, because it was a
Go ahead.
lot.
Yeah.
I will just start off by saying I still disagree with some of the other sections. So for me, I'm not ready to approve any language at this point today. Not to say that the rest of the committee necessarily agrees with that. I do agree that keeping the restrictions on the off-label use is okay for now. I think, you know, as we're expanding, we can always look to change that in the future. So I wouldn't necessarily include that change in there. Let's see. I think a lot of it is mostly rephrasing and trying to like streamline things.
Mhm.
Oh, and then the last, for section 4050, where it talks about pharmacy practice versus pharmacist practice, I also thought that pharmacist practice sounded strange. And I think the reasoning there about pharmacy practice being consistent with other parts of business and profession code makes sense. But I'm sure Corinne can provide us more clarification if needed. On whether or not that makes sense.
Okay. I think the intent on that was just to moving away from so much of a business model and moving
Yeah.
it to more of a clinician level. But I think that I get the understanding from both sides on that.
Oh, and I think where was it? Where it says D, they added a section for no state agency other than the Board of Pharmacy may define or interpret the practice of pharmacy. I think that was actually a really important inclusion to make sure that we're making it clear that other boards will not have the authority to restrict pharmacy practice.
Okay. I agree with that. Anything else, members? Because I think that we're not going to have motion today on this, but hopefully we'll have something for next meeting. So let's, or we can open up for public comments and then go from there.
Oh, sorry. Also, the addition where it says, let's see, under BPC 4051, Section 4, the pharmacist provides the service or activity in accordance with the accepted standard of care, including standard of care language explicitly, I think is makes a lot of sense too. So it's clear that what we're doing and that a pharmacist should be operating under that model and not just doing whatever they want if that's not the accepted standard of care.
Yep. Okay. All right. We will open up for public comment and go from there. David?
We are open for public comment. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise a hand, and we will call on people in the order we have requests. And our first request comes from Daniel Robinson. Hold on just a moment, please. We're going to send you a request to unmute your microphone.
Dan Robinson, thank you so much for allowing me to comment. And speaking on behalf of CPHA and the amendments and suggestions that we provided, number one, we want to really show our appreciation for the amazing work that the licensing committee has done to begin to move pharmacy, really support pharmacy practice through a different regulatory model. So the standard of care model does that beautifully, and it's the way other health professions are served as well. I'm very encouraged by the number of comments that support some of the changes that we've recommended. The issues about removing some of the language in, first of all, 4052 subsection A, these are all may statements, and there's 17 may statements that follow that. So it really shouldn't be implied that any pharmacist has to do any of those things or has to do all of those things, particularly if they don't feel that they're personally able to do it or they're not on a facility where that supports that type of activity. Also, there was this sentence that says the section shall not allow pharmacists to furnish medications for off-label use. We felt that was very restrictive. We ran into that situation with COVID. You know, we had something new that came along. Labels hadn't been developed. We could have a new virus that maybe would respond to a current vaccine. We don't want to have to be restricted because we want to be flexible and based on any emerging health threats. So we would like to see that removed. Also, we removed a small section, unless a patient's treating prescriber or otherwise prohibits such action. That was just sort of, you've already, this was in subsection 13, but I didn't hear any objections to that. And then we did change the language slightly, and number 17, adjust drug therapy regimens consistent with standard of care for chronic conditions, rather than medication therapy management reviews, which sometimes appear rather fixed, and often their reviews are published. They can be published as guidelines. But what we need to do, and pharmacists that are providing treatment in these areas need to be able to deal with whatever is current that they have to provide. Section 4052, this is a new statement. Pharmacists who make interventions as part of medication management shall document and communicate with other providers, which replaces all of the language in sections 11 and 12. So I guess my time is up. Thank you.
Thank you for the comments, Dr. Robinson.
Next, we're going to hear from Keith Yoshizuka. Hold on just a moment, please.
Thank you for the opportunity. Keith Yoshizuka, California Society of Health System Pharmacists. CSHP supports and applauds the board for their efforts to migrate to a more robust standard of care model. As President O had noted, there are some folks that feel that maybe it doesn't go far enough, and I have to admit I'm in one of those camps, but you got to start someplace. So, we support and applaud your efforts to migrate and to be more progressive in this area. Thank you.
Thank you for the comments, Dr. Yoshizuka.
Next, we're going to hear from Susan Bonilla. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Again, CEO for the California Pharmacists Association. Just wanted to express our gratitude and congratulations and thanks to the committee and the whole board for their work on standard of care. This is so timely and so important. We believe that this move is going to really promote better patient access and equity ultimately in the profession of pharmacy. I wanted to recognize Dan Robinson's work over many years on this topic, and also the entire work group that came together to put the suggestions for clarification and changes that you received. It is a very well respected group of pharmacists who worked on this. And I wanted to say that we are very encouraged by the work of the board and the staff of the board. We are stand ready and able to work with you in explaining maybe some of the points that you find in the letter. We look forward to really a collaboration here as we continue to refine this very, very important move, and frankly, a move I think that's going to capture national attention and set a standard for other states across the entire nation. So again, thank you, and please let us know how we can continue this excellent collaboration. And again, the work group stands ready and able to partner with you in any way that would be helpful. Thank you.
Thank you for the comment, Susan.
Our next comment comes from Stephen Gray. Hold on just a moment. We're sending you a request to unmute your microphone.
Thank you again. I also applaud the board and its efforts to go forward. It's been a multi-year process, learning about the evolution of pharmacy practice and what that means and where it's going and how it can benefit patients and people in California the most. I do have a couple of comments. This is all about going to the standard of care concept for the regulation of pharmacist practice. So I respectfully disagree with the recommendation made by CPHA. I think it needs to be clear, as the board has proposed, that this is about pharmacist practice. It's not about the business of pharmacy, which probably cannot go to as much of a standard of practice regulation process because pharmacies are not owned necessarily and operated by pharmacists. So I encourage the board to retain that distinction. As far as number 8 goes, I understand what you're doing there, I think, but you need to realize that will receive strong opposition from state and local governments because it affects the sales tax. When an OTC medication is prescribed, it is exempt from sales tax in California, and that will have strong opposition, I presume. And then generally speaking, just to be clear, when you look at across semantics across jurisdictions, some jurisdictions differentiate between a standard of care and a standard of practice. I think the board needs to understand and the public needs to understand what you're going for. Standard of practice usually means you're compared to someone with the same license, with the same education, training, conditions, etc. Standard of care means you live up to the strongest standard of care, regardless of what the license is. I just think that a little research or opinion from council as to what the solid legal definition and understanding is in California between those two definitions. You may want to consider changing it to standard of practice when you get down to statutory language. Thank you very much.
Thank you for the comments, Dr. Gray.
That was our last request for public comment.
Thank you. All right, so I am thinking that this topic also may warrant a just separate meeting in the future, probably. So that may we might survey all of you to see if there's a date that may be available in addition to our current licensing committee meeting dates. So we'll keep you all apprised, and at this point in the next, in the future meeting, we'll try to come up with a proposal considering all the comments that were received today. And maybe we can have a little bit more thorough discussion on this very important topic. So we're ready to move on to next agenda item. But before, I just want to make sure there's anything else that any members want to say about this topic. Okay, we will move on. Now, it's 1:05. I am planning to adjourn this meeting at 1:15. So we'll try to tackle this next item really quick. So it's agenda item 12, discussion and consideration of Senate Bill 523 related to contraception access, including possible amendments to Business and Professions Code sections 4052 and 4052.3. As included in the meeting materials, Senate Bill 523 made changes to expand coverage for contraception by a healthcare service plan, contract, or health insurance policy. As part of these changes, OTC FDA-approved contraceptive drugs are now covered under these specified conditions. However, regrettably, implementation of the policy goal of the measure has not been realized because of the reimbursement requirements, most notably a requirement by payers to have a prescription to reimburse for medications. To remedy this, it appears to change in Business and Professions Code 4052.3 and potentially a conforming change to BPC 4052 are necessary. As we begin our discussion, I'd like to note that if the board's standard of care proposal is enacted as drafted, the proposed changes here would not be necessary. But this is again a very baby step, just so that we can have something if our hopeful standard of care proposal does not go forward. Hope that makes sense to you all, and open for comments, questions, and a motion that is available for all of you to proceed, at least on this very baby step. Jesse, go ahead.
Hey, Son. I'm honestly a little confused on this language. So I know we're adding the prescription only language in subsection A. But then the language in D is a little confusing to me, where it says a pharmacist may furnish FDA approved over-the-counter contraceptives without the need to comply to standardized procedures or protocols required for prescription only self-administered. So is this just trying to make it so that pharmacists can prescribe the over-the-counter version as well?
That is the intent, yes.
Okay. So then for clarification purposes, are we keeping the language as furnish in subsection D, or did we intend to change that to prescribe?
That's a great comment, and I'm going to defer that to Anne and Corinne, our lawyers. I think sometimes lawyers make the language sound so confusing for our normal people to be confused by. So, Corinne, Anne?
So I think probably if agreeable to everyone, if you can focus on the policy and then we can try to further refine the language. I think the intent of the language is to make it clear that the current statute related to hormonal contraception and the protocol are not required for OTC. So that's, I think, what it all kind of boils down to. So if you all tell us the policy direction, if you agree, and how to, what you want that policy to look like, then potentially we can work offline to kind of clarify that language and bring it back.
Okay, thank you. That's helpful. So then, so I know we're working on this as essentially an alternative to the whole standard of care language, right? So is the language intended then that a pharmacist would just be able to write a prescription for the over-the-counter product without having to do any of the other administrative steps involved? Okay. Perfect. Well, thank you for clarifying that. This was a lot, but I'm comfortable making the motion to recommend to the board amendment to Business and Profession Code 4052.3 and confirming changes to Section 4052 as deemed appropriate, and also allowing the executive officer and staff to wordsmith the language pursuant to our discussion.
Thank you, Jesse. Any second?
I'll second that.
Thank you. Was it Satinder or Trevor? Is it Satinder? Satinder. Okay. All right. Thank you, Satinder. All right. With that, we're ready for public comment.
We are open for public comment. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise a hand. And I see them popping up. First comes Lindsay Gullahorn. Hold on just a moment. We are sending you a request to unmute your microphone.
Thank you. Hi, Lindsay Gullahorn with the California Community Pharmacy Coalition again. Just want to thank you for looking into this and attempting to address this issue. We didn't have any issues with this bill last year when it was moving through the process, but identified it early this year as problematic to implement because of the reimbursement and prescribing issues. So support what you're doing in concept and look forward to supporting this as it continues to move. Thank you.
Thank you so much.
Next, we have Lori Walmsley. Hold on just a moment. We're sending you a request to unmute your microphone.
Hi there, Lori Walmsley on behalf of Walgreens. Really appreciate the discussion and the board's potential action on this. I think this is a great step forward to further make contraceptives available in the state of California. There are a number of patients that may be excluded from contraceptive access from it being covered based on the screening questionnaire and things like that, even though the product is widely available OTC. So I think this is a great step forward and will help to further access in California for the benefit of the citizens.
Thank you for the comments, Lori.
Next, we're going to hear from Sally Raffi. Hold on just a moment. We're sending you a request to unmute your microphone.
pharmacist. I also wanted to echo the sentiments, thanking the committee for moving this forward. It is a time-sensitive issue around contraceptive access, and there's presently an equity issue where Medi-Cal patients are not able to access the OTC product that's now available over the counter. So this is an important step in the right direction. So thank you so much.
Thank you so much, Dr. Rafi.
And that was our last request for public comment.
Thank you, David. Okay, thank you, everyone. I really appreciate all the time and commitment for the California consumers. We'll tackle agenda item 13 and 14 during
President
our
O,
regular.
I apologize. Would you mind taking a vote on that last motion, please?
Oh, I vote yes. I will vote. Oh, okay, okay. Sorry, Ann. Thank you. Trevor, how do you vote?
Yes.
Thank you. Renee, how do you vote?
Yes.
Thank you. Jesse, how do you vote?
Yes.
Thank you, Satinder.
Yes.
Thank you, Jason.
Yes.
Thank you, and I vote yes. All right, thank you, everyone. We'll tackle those at the full board meeting. I think we covered everything that we needed to really. So thank you for your time, and I hope everyone enjoys the rest of your day. And for some who has to go to public ed committee, I'm so sorry for such a long day. But we'll see you all later, and we'll keep you all posted on the possible future meetings for standard of care meeting. Thank you.
Thank you. Thank you. Bye.